Good morning. Well, it's an honor to be here. It's a pleasure to be speaking to you all. I especially want to thank Heather and Alzheimer's LA for the invitation. It wasn't in my intro. I'm not sure if it's in my bio, but I actually worked at UCLA for 8 years and had the joy the joy of working with a lot of the folks who still are part of Alzheimer's LA. I've now been at UC Irvine for just over 10 years, but it is a very close-knit community of people who are doing research to try to help families living with all forms of dementia. And so a lot of us that you'll hear from today speak routinely and work together frequently because this is part of a larger mission in which we're all honored to be a part of trying to find solutions for you and people like you. As you heard, I've been asked to lay a foundation for what you'll hear the rest of the day and talk a little bit about how we got to where we are in the state of clinical research for Alzheimer's disease and other causes of dementia. I adjusted the title a little bit to past, present, and future because how we got here is absolutely important. Where we are is incredibly exciting, and where we're going holds remarkable promise for really changing the conversation about Alzheimer's disease and other causes of dementia and changing the public health impact of these conditions. These are my disclosures. Relevant is, one, I'm not a clinician. I'm a PhD who retrained in clinical research, but I have been involved in a lot of clinical trials, including clinical trials that are sponsored by companies like the ones, including the companies sponsoring part of today's activities, and trials of new medications that have been recently approved for the treatment of Alzheimer's disease. I also hold some editorial and other relationships, but little, if any, personal financial gain from any of these things. What I'm going to try to do is walk us through how we got here, where we're at, and where I think we are going. So first, it's important to begin with the most foundational step, which is to define research. And in particular, when we think about clinical research, I'm highlighting the difference between clinical care and clinical research. In clinical care, you're interacting with a physician or another clinical provider whose job is to do what's best for you in that moment. There's an important difference in clinical research. In clinical research, we're not trying to help just the person in the room for that visit. We're trying to help every person in every room around the world now and in the future. This creates a tension. This creates a risk that a person participating in research won't receive the best possible thing for them so that we can try to learn, gain knowledge, and improve the practice available to all. Because of this risk, because of this tension, the real heroes in research are not the people who've earned the lofty titles that are long to announce at the beginning of their talk. The real heroes in research are the people who enroll in the studies. Some of you in the audience are the people that let individuals like me try to make the contributions we want to make to help everyone dealing with these diseases. The people enrolled in studies are the people that have allowed us to transform the clinical care available for people living with Alzheimer's disease and other causes of dementia. Those who do not learn from history are condemned to repeat it. And we have an important history in clinical research. There are incidents in our history that have guided where we are now. And I'm speaking about clinical research in general and the inclusion of unfortunate incidents, atrocities in some cases, like the Nazi doctors who committed unspeakable acts in the name of science, and produced some of the first ethical guidelines when they were judged at the end of the war. The Nuremberg Code from the Nuremberg trials is among the first formal guidelines for the ethical conduct of research. Interestingly, the Nuremberg Code dictated that only when a person could give informed consent could they be enrolled in a study, which would limit the ability of many people, especially in the severe stages of dementia, from participating in research. This was later corrected by the Declaration of Helsinki. After the war, this was viewed as unspeakable things done by barbarians in Europe that couldn't happen here in the United States. The Tuskegee syphilis experiments and other acts committed here in America, outlined in a famous article by Henry Beecher in the New England Journal of Medicine, made clear that risks are apparent wherever research is being done, and precautions must be taken to protect the safety, the integrity, the autonomy of people enrolled in research studies. We now have a code of federal regulations, a common rule that dictates anyone conducting research in this country be held to the very high standards to ensure the protection of participants. Drug development has its own history in this country. I teach an undergraduate class in clinical trials, and every year one of my questions is true or false, clinical trials have been around for centuries. It's false. We're still in our early days of learning how to develop medicines and improvements to the care of people through this rigorous science. We've only had an FDA for a little over a century, and the earliest laws creating the FDA said only that the label to sell a drug had to actually represent what was in the product being marketed. It was only through unfortunate incidents that we achieved a more modern state of the FDA, which eventually mandated that clinical trials were necessary to demonstrate that a new treatment was both adequately safe and efficacious, and a modern FDA approval status, which dictated that multiple clinical trials were needed before a drug could be marketed and sold in this country. Why do we need these studies? Why do we put so much emphasis on clinical trials to bring new medicines into treatment? Because it's the only way to know with certainty that drugs are adequately safe and effective for use. Numerous studies in our literature show us that biases run rampant when rigor is absent. Patients want to do better and often do better over time. Doctors want to help their patients and perceive that their actions are beneficial. In order to counteract these potential biases, we need scientific rigor to answer questions about new medications before they can be used in practice. The gold standard approach to doing this is something called the double-blind, placebo-controlled, randomized clinical trial. Placebo is an inert substance identical to the treatment that is being tested in a clinical trial, indistinguishable in every way, yet inactive. If we're testing an oral medication, the placebo might be, we typically say sugar pill. It's not generally sugar. If we're testing an infused medication, we would infuse an IV saline that lacks the medication. I've even been part of a clinical trial of a neurosurgical intervention where patients assigned to the control group had scalp incisions and non-partial burr holes drilled into the skull. The only way to feel confident about a treatment, the only way to assign causality instead of association, is through a rigorous randomized clinical trial. Randomized Because typically half of the patients enrolled in a study will get active medication and half will get the control, often a placebo. By randomizing people, meaning that each person in the study has an equal probability of being assigned to each arm of the study, we know that the groups should be identical. Identical, not just for the things we measure, but for the things we don't measure. And thus, differences at the end of the study can reasonably be concluded to have resulted from the only difference between those groups, who got active drug and who got a placebo. This is the gold standard. Anything less than it risks bias. As practices progress, we may do different types of clinical trials. We may compare new drugs to previously approved drugs. Sometimes we refer to those as non-inferiority trials. We can see if a new drug is better than an old drug, a superiority trial. But the randomization, the control group, the rigor is essential. You may have heard phrases like phase 1, phase 2, and phase 3. Indeed, for most drug development, new potential treatments we're excited about, will work through these phases. Phase 1 studies are often first in human, the first time we're giving something that we believe holds promise to actual human beings, often done in young, healthy controls, but in some cases done in patients afflicted with the disease we're trying to help. For example, testing a vaccine against the beta amyloid protein known to accumulate in the brain of Alzheimer's disease in only Alzheimer's patients. More often, we save first in-patient experiences for phase 2. Still somewhat small studies, with phase 1 studies generally being very small. Our goal in phase 1 is to learn about how a drug spreads through the body, how long it stays in the body, how long it takes to leave the body, and to make sure that we can give the new drug safely to human beings. In phase 2, we're looking to see if we can give the new drug safely to the patients we're hoping to help, the patients who are afflicted with the condition. And we will look for hints about whether the drug has promise and should be continued in development. And often phase 2 includes many studies. Is promising, we'll move to what we call phase 3. These are the studies for which the results may be reported on CNN, MSNBC, Fox News. They're large trials. They may change stock prices for drug companies depending on whether they're positive or negative. They are intended to be adequately large to tell us whether the drug is efficacious or not. Does this drug help patients? And on the backs of these trials, the FDA may approve a new medication. This is also a slide from my course. I've given this slide to undergraduates. I've given it to the other directors of the nation's Alzheimer's disease research centers because it's not adequately understood. You'll hear people say that we've had hundreds of failed clinical trials for Alzheimer's disease. I disagree. We've had many clinical trials that were negative. We didn't find the treatment that was being studied was a solution. It shouldn't be carried forward into clinical practice. But it wasn't a failure. It was an important step. It succeeded in answering its question. And the many clinical trials that we've done over the last 30 years in Alzheimer's disease are how we got to where we are today. And where we are today is exciting progress. In the past, Alzheimer's disease and other forms of dementia could only be definitively diagnosed after a person passed away when we examined their brain. We gave someone a diagnosis of possible or probable disease if the diagnosis was given at all. We had very few treatments that were limited in their efficacy and did nothing to slow the course of the disease. Now, it is a different time. Over the last several decades, research progress has begun to change the clinical practice of caring for older adults with dementia, older adults with cognitive impairment. We have new tools to support this practice. We have brain scans that can show us the hallmark changes associated with Alzheimer's disease, where they're occurring, how much there are, if they are present or absent. We have cerebrospinal fluid assays that give us information about those same proteins, as well as the amount of neurodegeneration, with promising indicators for other things, like the health of connections between brain cells. And now we even have blood tests that can give us similar information about whether Alzheimer's disease plaques and tangles appear to be present in the brain of a person with cognitive impairment. Close behind are assays to tell us if someone has alpha-synuclein, the protein culprit in Lewy body dementia. And work is ongoing to understand whether biomarkers can help us diagnose other causes of age-related cognitive problems. Similarly, we have had decades of progress in drug development, again made possible by people who participated in many, many clinical trials, all of which helped us advance, helped us progress, learn about drug targets, patient enrollment criteria, and the best ways to demonstrate if a drug has benefit for patients. After a 20-year drought, we've had 3 new FDA approvals for drugs for which the data are convincing can actually slow the progression of Alzheimer's disease. Much work remains needed. How much can these drugs slow the disease? For how long? And if we start these drugs earlier, are the benefits greater? There are still important questions. There are also still very exciting treatments in the pipeline that need to be tested in rigorous clinical trials to grow the available armamentarium for clinicians to provide their patients to best treat these diseases. These new biomarker tests let us rule in Alzheimer's disease compared to the age-old process of ruling everything else out and being left with Alzheimer's. These new treatments are changing our recommendations. They're changing our approach to clinical care. My belief is that every person getting a diagnosis of Alzheimer's disease deserves to hear about these treatments and ideally deserves to hear about clinical trials for other promising treatments that are still coming. If these treatments can successfully prolong life, slow the course of disease, they may extend the period of time a person lives with dementia. This is something we will have to address as a field. These conditions are associated with stigma. I worry that that stigma knows no bounds. We have to change the conversation about dementia and its many causes. Another major step in progress, partly driven by one of your speakers later in the day and his work in dementia care navigation, was when Medicare agreed to reimburse for dementia care navigator programs. Critically important progress for our field, for our nation, for our society, but still much work left to be done. Patients with dementia under 65 can't have Medicare pay for their navigator program. And many diagnoses are now made before a person's cognitive impairment is sufficient to fulfill the criteria for dementia, what we call mild cognitive impairment. We need care navigator programs for all older adults living with cognitive problems. I'll close with just a few comments about the future. We increasingly understand that most individuals living with cognitive impairment as older adults suffer from not one, but more than one neurodegenerative disease. These are data from our UC Irvine Alzheimer's Disease Research Center. I appreciate that it's a tricky image. The overlapping figures show how many people have the different pathologies that can cause cognitive impairment. you'll see that in our cohort, which is probably biased towards Alzheimer's disease, the majority of people do have the plaques and tangles we associate with Alzheimer's disease. This is from our brain bank. But we do see tremendous overlap and frequency with which people have Alzheimer's disease and another form of neurodegeneration in their brain. Our future must include better diagnostic technologies for all of these pathologies so that we understand the many potential causes of dementia, and clinical trials with combinations of treatments for people with combinations of pathologies. It is also clear from work in Alzheimer's disease specifically that at least for Alzheimer's disease, these pathologies accumulate over years, if not decades. And using those same technological advances to identify the biology of Alzheimer's disease, we are now testing treatments that can lower the amount of amyloid plaques in the brain in individuals for whom the plaques are present, but the cognitive problems have not yet begun. Many of us believe that treating the disease before the symptoms begin could delay or prevent the symptoms from happening. And this is how we think we can truly curb the public health impact of Alzheimer's disease. Key to the opportunity to engage in clinical trials at the earliest stages have been this revolution in diagnostic technologies. And I told you that while brain scans really got us to where we are today, blood tests are poised to take us where we need to go tomorrow. But I feel compelled to share something I've been thinking a lot about, which is that we still have work to do to change the stigma of Alzheimer's disease and other causes of dementia. And I am alarmed that there are now companies taking these technologies and marketing them direct to consumers as a way to learn if you may someday get Alzheimer's disease. These technologies do not replace an evaluation by an expert clinician. There are also great concerns around confidentiality, around legal risks. There are no legal protections for individuals assigned a label of Alzheimer's disease through biomarker tests. Much of my own work has been in the space of the safety of delivering biomarker results to older adults who do not have cognitive impairment. But in this setting, I have concern about the needed education and counseling to help people make choices about whether to learn this information. My concerns stem from the fact that we simply do not yet live in a dementia-friendly society. But I am optimistic that this is changing. The progress we are making in research, because of the contributions participating in our studies, made by people participating in our studies, are helping us change the conversation. Someday, I hope, we will use blood tests for every person reaching a specific age to understand whether they may be at the beginning of a journey, helping them navigate that journey, hopefully including treatments to delay the onset of memory and other thinking problems, and navigating the course of cognitive impairment and dementia, if that will occur, to maintain their dignity, to maintain their autonomy, and to support their family members and in what is often an arduous journey. I want to acknowledge my colleagues at the UC Irvine Institute for Memory Impairments and Neurological Disorders who engage with me in this work. I want to thank the agencies that fund our research, and most importantly, I want to thank the hundreds, if not thousands, of people who have participated in studies with me, and the tens of thousands of people who have participated in studies to support our field. Thank you very much.
Dr. Grill does have time for some questions, and we have some people in the audience with mics. So if you have a question for Dr. Grill, I see one in the back. Go ahead, Kelly.
How does vascular dementia fit in with all this?
Yeah, it's an excellent question. So some of the studies suggest that as many as half of people with Alzheimer's disease also have vascular injuries to the brain. This could be small or large strokes. It's definitely a common comorbidity. Vascular dementia would be typically described as presenting differently from Alzheimer's disease or the other proteinopathies, sorry for the big word, but the forms of dementia that are caused by abnormal accumulations of protein in the brain. In vascular dementia, we think of a more sudden or abrupt onset with a staircase-like progression where someone gets a lot worse over a short period of time compared to the neurodegenerative causes where we have a more slowly progressive continual decline. You're going to hear, I think, about brain health, and a lot of what we know about brain health is about lowering our vascular risk factors, so our cholesterol, our high blood pressure, maintaining a healthy diet, exercising. These are all things that we think maintain a healthy vascular system or cerebrovascular system. We actually have more capillaries in our brain than brain cells, and so keeping the blood flowing to the brain is hugely important, and there are definitely studies that find a link between the plaques and tangles of Alzheimer's disease and the vascular risk factors as eliciting more progression through the course of the disease. So I think in the future, the combination therapies could be more than 2 treatments. It may be cocktails of treatments, and some of those may address the vascular components, others addressing the specific proteins that accumulate in the brain.
I see Natalie over there on the left, our left, your right.
Hi, thank you for your information. I had a question or a clarification on placebos. We're in a study right now, in fact, the 1812 at UCI, but actually we're on hold until they figure out the count. In the discussion of it, I was asking about the placebo and then possible post-placebo treatment. And it's an 18-month study, and I was told that there was no plans right now for post-label or off-label treatment. I'm wondering how the ethics of that are decided.
The question is about after a clinical trial in which someone is randomly assigned to an active treatment or a placebo. Many clinical trials will choose to continue to follow patients after their specific period of participation. That, in this case, is 18 months. We've seen studies of 12 months, 6 months. I'm part of a study that's 4.5 years long in another setting. At the end of the double-blind period, where someone is randomly assigned to drug or placebo, we often follow people over time, and we remove the placebo. We call that an open-label extension because it's open, it's no longer double-blind. We know that everyone is getting active drugs. So the people who are on placebo get switched to active medication. Not all trials do that. There's a lot of benefit to doing that. It gives us longer-term safety data, which could be extremely valuable if that treatment is taken into clinical practice. It's not perfect, but it can also give us novel data about whether treatments actually slow the course of the disease. I'm a big proponent of them, but they aren't always done. And in particular, if a drug company is involved in the trial, it's really on them to provide the drug and continued funding for following people. And if the trial is funded by a small grant, we may not have the funding to follow people long-term on treatment. As far as the ethics of that, it's what we like to do. We understand people value access to these treatments. If you ask why people participate in research, there are 2 common answers. I want to help, I'm altruistic, and I hope I get something out of it. I hope I benefit by getting access to a new, promising treatment that I otherwise could not have access to. Both are completely appropriate. Both make good sense to me, and I find them both to be purely, very ethical. Unfortunately, there are some barriers to us always doing open-label clinical trials, and that's just a reality. What's most important is that when someone enrolls in a trial, we give them as much information as is available to us, including whether or not an extension study is planned.
So we're going to take one more question. I see one over here.
I was curious about where Lewy body fits into your research.
Lewy body dementia is caused by a different protein accumulating in the brain, alpha-synuclein. There are some promising data for some medications to treat Lewy body. They remain investigational, that is, they remain in clinical trials. Again, we know that we have patients in our cohort who suffer from Alzheimer's disease as well as Lewy body disease. We are taking a lot of important steps now about doing clinical trials for multiple etiology dementia, but I'll admit Lewy body disease has not been our primary focus at UC Irvine. There are other places that are focused on that, like the Mayo Clinic in Rochester, Minnesota.
Please help me thank Dr. Grill for his wonderful presentation.
Prior to my current work of health education in the community along with clinical research, I was a primary care physician for close to 20 years in Orange County. And as a physician taking care of mostly senior patients, older patients, I saw the entire trajectory of Alzheimer's. I knew my patients when they didn't have Alzheimer's. They drove in, we had great chats, great conversations, and over time, there was little small changes, which initially was just blamed on getting older, right? Getting older. So nobody thought of anything about it. And over time, things didn't get better. And at some point, the patient's caregiver, the patient's spouse points out things to me. Dr. Trinh, my loved one's cooking, not turning off the stove. Or why is the keys in the refrigerator? And now they're driving home and they get lost sometimes. Alzheimer's is the number 3 cause of death in our area. How many of you guys knew that? How many of you guys are learning it now? It's a disease that affects not only memory, but behavior, personality changes, thinking process. We always think first about memory, right? But there's a lot more involved with that. How many of you guys are aware that there are 14 lifestyle and health conditions and factors that contribute to up to almost half of global dementia cases, and that most of these conditions are modifiable through lifestyle? Yes, there are genes, genetics connected with this disease, but we know that for the most part, lifestyle plays a huge role, probably a bigger role than genetics. How many of you guys have heard of the amyloid plaque? How many of you guys have heard of tau? Yeah, about half-half? Great. Let me share you a little bit about the science behind the plaques and the tangles, tau tangles. Because if you understand the science, you'll understand the need for early detection. Quick question. How many of us here, once a year, every year, get a little memory test from your doctor? Raise your hand. Wow, maybe 10? Why is that? So if Alzheimer's is the number 3 cause of death, by the way, does anyone know number 1 cause of death? Heart disease, yes, heart attacks. Does anyone know number 2? You guys are smart. Cancer, yes, and number 3 is Alzheimer's. What do we do for the number 1 cause of death as far as detection and prevention? You get your cholesterol checked. If it's high, right, it's a risk factor for heart attacks. You get your blood pressure checked. If it's high, it's a risk factor for heart attacks. You get checked out for diabetes. If that's not good, it's a risk factor for heart attacks. Your doctor tells you to exercise and lose weight, stop smoking, right? We do everything we can to reduce the risk for the number 1 cause of death. Number 2 cause of death, cancer. What do? Sunscreen? Okay, awesome. I need some of that myself. Colonoscopies, right? Colon cancer, mammograms, breast cancer, PSA, prostate cancer, pap smears, cervical cancer. We do everything we can to reduce the risk for the number 2 cause of death. What do we do for Alzheimer's, guys? Nothing. Is that not a problem? Is that why we're here today? Absolutely. In a healthy brain, we each have around 100 billion brain cells in a healthy brain. Every time you're thinking, your brain cells are connecting, they're chatting, they're communicating every thought that you have. Every feeling, every emotion is simply brain cells connecting, chatting, communicating. With Alzheimer's disease, the plaque that we talk about, the beta amyloid, the protein that is associated with Alzheimer's, what it does is that it physically gets in the way between 2 brain cells trying to communicate, and it blocks the communication. And initially, in the beginning, it's no big deal, right? Little bit of plaque, not a big issue. But as time goes by and plaque builds up silently, quietly, without any symptoms or sign, as plaque builds up, there is a general correlation that memory gets worse because of that communication issue. It's not 100%. We've seen people with a lot of plaque in their brain with great memory. It's not 100%, but there's a general correlation that as plaque builds up, memory gets worse. That block in communication between 2 brain cells. That's the Alzheimer's plaque. Now, what do you guys know about the tau tangles? Tau tangles, what's the difference? So tau is a protein that's actually normal. The tau protein is normal. It lives inside of the brain cell. And it makes up part of what I call the rebars of the cell. You know when you're building a house, you got these rebars that help with the structure of the home, right? So the cells have rebars. They're called microtubules. And so the tau protein is part of the rebars, is part of the microtubule, and not only does it help with the structure of the cell, those microtubules are also information highways where information goes back and forth. In Alzheimer's disease, what happens is this. The tau protein, which is part of the rebar, gets phosphorylated. There's a phosphate group that binds to the protein in Alzheimer's disease. And when the phosphate group binds to the tau protein, it dislodges the tau protein from the rebar. It dislodges it from the microtubule. And as these phosphorylated tau is falling off the microtubule and dislodging from the rebars, if you have a weak frame of the house and the rebars are becoming weak because tau tubules are falling off of it, right? Phosphorylated tau, what happens to that infrastructure? It's not good, is it? As a matter of fact, these phosphorylated tau, as they fall off, they tend to tangle up inside the cell. And that starts the process of cell death, where the brain cells are dying. And what activates tau, there's many different factors that activates the phosphorylation of tau, but the presence of the amyloid plaque is also a trigger. Quick question. By the time somebody has their first memory loss from Alzheimer's disease, how long has the amyloid plaque been building up? 20 years. Around 2 decades. Silently, quietly, no symptoms or sign. Crazy, isn't it? 2 decades. And what we see is this. Plaque builds up first. And then tau comes after in the blue. So the amyloid beta plaque is in the red. A few years after amyloid buildup, you have the presence of tau that builds up. Because amyloid triggers tau. That's why tau comes after. As tau, phosphorylated tau, neurofibrillary tau, tau tangles, as they build up, the cells begin to die. Brain cells begin to die. We have a word for that, neurodegeneration, the loss of brain cells. How do we know this? We know this because in Alzheimer's patients, every year as the disease progresses, the brain starts to shrink in size. We can do an MRI every year on a patient with Alzheimer's, and their brain shrinks in size. It gets smaller and smaller and smaller. And the reason it shrinks is because brain cells are going away. We're losing brain cells. So if you look at what follows the blue line, which is tau, is the yellow line. It says structural MRI. It means the size of the brain, you're losing brain cells, and we can see it on an MRI, a shrinking brain. You guys seeing it? When does memory loss start? It starts in that purple line. Memory loss starts years after brain cell death have begun. Years after brain cell death have begun, do you start to have memory problems? Clinical function in green, clinical function is when you start to lose the ability to take care of yourself clinically. Cooking, cleaning, changing clothes. So if we are checking for memory loss, just realize that first of all, if you have memory loss associated with Alzheimer's disease, there's already been years of damage. And the problem today is that I only saw a few hands go up when I asked you who's actually getting a memory test. This is why Alzheimer's is the #3 cause of death. We are not even looking for the condition, guys. And by the time our patients come to the doctor and says, we have a problem, there's been progression. In the mild stages of Alzheimer's, we're all blaming memory loss on what? Getting older. Is that not a problem? When you look at the science, who wants to wait for a symptom that is severe before you talk to your doctor? When you look at the science, the damage has been done for years. Why early detection? How many of you guys actually want to know if you're at risk? Yeah, some do, some don't. It can get a little scary, right? It can get a little scary with that. But why even look for early detection? The most important thing is this. We now have data that's been published, right? We were at, I saw Dr. Grill there in Toronto. The Alzheimer's Association International Conference was a few weeks ago, not that long ago, where there was published report and presentations on lifestyle. Doesn't even include a pill or a prescription, on lifestyle and the ability of modifying lifestyle in the early stages to try to change the trajectory of Alzheimer's disease. What would you guys do if you knew you had a high risk for Alzheimer's disease? What would anyone do? Take extra vacations, get your financial, legal paperwork in order. Consider FDA-approved medications that are designed to remove and slow down the progression of Alzheimer's disease. There's a lot that can be done, but the most important thing is early detection. The most important thing to me is this. There are 14 lifestyle factors that can prevent or delay up to 45% of dementia cases. They've been identified, guys. They have been identified. Blood pressure, obesity, smoking, diabetes, depression, physical inactivity, education, socialization, hearing loss, alcohol use, air pollution, head injury, diet, and sleep. Are not most of these lifestyle? So if you look through the list of modifiable risk factors, just these 14, and there are probably more than 14, If you look and see, what am I at risk for in these 14 things? Imagine if you can change and modify your lifestyle to lower that risk. There's no guarantee of 100% prevention because genetics play a role. But these are the things that you can do today without taking a pill. Let your food be your medicine, and if needed, a prescription. But start with lifestyle first. The problem is, our community does not know and are not aware that lifestyle plays a huge role in the risk for Alzheimer's disease. Many of us just think, Alzheimer's is coming because I'm getting older. There's nothing I can do about it, so why find out? But there's so much that you can do about it. So much. So, how many of you guys are going to go back to your doctor and ask for a memory assessment? Not enough hands. Still a little scary, huh? It's very important because if you're not even looking for the condition, how are you going to find out if you're at risk or not? How are you going to find out if you're not looking? Thank you. Early detection, super important. You can take your brain health into your own hands. Thanks.
Okay. Questions for Dr. Trinh? Ooh, there's a lot. All right, so I see Kelly's going over here in the center.
Thank you so much. The question I had, the lifestyle changes, do they help people who are already in the purple or the green stage?
Great question. Is it ever too late to start lifestyle changes? My answer would be no, it's never too late, but you get more benefit the earlier you start. Does that make sense? Like in the advanced stages of Alzheimer's, so many brain cells are already gone. We cannot bring dead brain cells back. So you got to start now while you got your brain cells. The earlier, the better.
So Natalie is over here with a question.
If you've been tested for the APOE4 genes and you don't have them, are you still likely to get Alzheimer's?
Great question. The question is on genetics. And how many of you guys have heard of the APOE4 gene, right? That is one of many, it's not the only one, that is strongly associated with Alzheimer's disease. And the question is, if you do not have the gene, does it guarantee that you won't get Alzheimer's? The answer is no, because lifestyle plays a larger role than that gene. Now, if you have the gene, the APOE4 gene, it does not guarantee that you'll get Alzheimer's either, because lifestyle plays a bigger role with that. Whether you have the gene or not, lifestyle.
So in the back with Steve over here.
So on that same idea, if somebody has the APOE4 gene, what's the research that's been done around these 14 lifestyle factors? In other words, it says delay up to 45% of dementia cases. Are those with people with or without? And if they have the APOE4 gene, then what are the numbers we're talking about?
So, great question. This was actually presented at the Alzheimer's Association International Conference recently. In one of the presentations, if you have the gene and you implement the lifestyle, and you implement it well, it has a higher benefit at moving the trajectory than those who don't have the gene. Now, everyone should live the lifestyle, absolutely, but because your risk is higher with the gene, the APOE4 gene, if you implement the lifestyle, you have a higher benefit with lifestyle from what I've seen.
Oh, back there.
Thank you for your presentation. You said that Alzheimer's is the third leading cause of death. What does that actually look like?
Nobody drops dead from not remembering. What happens is At the initial stages, no worries, forgetting this, forgetting that. But over time, as disease progresses, you forget how to take care of yourself. You forget to take your pills, so your blood pressure's out of whack, your diabetes is out of whack. You forget eventually to take care of yourself, so we have to get help into the home. And then help in the home is not adequate, so I would send my patients to nursing homes and things of that sort. That's where patients die. That's where patients die. You forget that you're even hungry, and you no longer have conversations. You end up bedbound.
So we're going to go to Natalie, who's over on your left.
I have loads of questions. I just want to commend you on being an amazing and such a diligent physician, because it's so hard to find anybody, who really actually thinks past just their scope of work. My question is there any relation with fibromyalgia and dementia?
Fibromyalgia and dementia. I haven't seen a lot of research in that, but I do know that fibromyalgia patients tend to be depressed, and there is a relationship between depression and Alzheimer's. I know that fibromyalgia patients with chronic pain tend not to exercise, and so there is a relationship with the lack of physical activity and Alzheimer's. So the associated symptoms is what you want to look for, not necessarily the diagnosis of fibromyalgia.
Fibromyalgia was actually the start and the beginning of my mother's Alzheimer's that has just been diagnosed. 15 years ago, she was diagnosed with fibromyalgia because they couldn't figure out what was wrong with her.
With fibromyalgia, sometimes you tend to, with chronic pain and depression, you just end up isolating yourself and are often at home and not socializing, not using your brain, not going out, and not exercising. And so these other associated symptoms are often linked to the risk of Alzheimer's disease.
So we're going to go in the back to Steve.
Hello, thank you for your presentation. Could you talk a little more about the blood tests regarding tau, the new blood tests?
So the blood test that we have today is blood tests that are associated with the plaque. The Alzheimer's amyloid plaque is the association of that blood test. Although the name of the blood test includes the word tau, like the p-tau217. You think that it's correlating to tau, but it's actually a correlation to the Alzheimer's plaque.
Toward your left.
Hi, thank you so much. You talked a lot about getting annual screenings. Is that from a neurologist or your general doctor? And I'm speaking from a person who has significant direct family history with the illness. So I'm wondering if that's something because of that I can get earlier on, or there's additional testing. Who do you recommend to go to?
There are not enough neurologists in the country to give everyone who needs an annual memory screening a memory screening. The memory screening, the cognitive assessments, is normally done by your primary care doctor, usually done once a year, either at a physical exam, or there's another assessment that we do called an annual wellness visit. How many of you guys have had an annual wellness visit? So in the annual wellness visit, it includes a memory assessment, right? It's paid for by Medicare, it's covered, and that memory assessment is included in that annual wellness visit. Primary care physician.
Okay, so we have up here toward the front on our right, Dr. Trinh with Natalie.
Hi, thank you so much, Dr. Trinh. When I'm a provider, but also a family member of someone with dementia, and I wondered about, obviously, I'm so glad you're talking about talking to doctors, and I wondered if you could talk more about the people who have not had this memory screen, and we're encouraging them to talk to their doctors. I know that a lot of physicians aren't comfortable having conversations. They talk about not wanting to mention the D word, and if you have any recommendations for people onto what physicians, if they feel like their primary care doctor isn't addressing that, if there are other specialists they should seek out.
So if your primary doctor isn't addressing it, get another doctor.
Get another doctor.
I know that that's easier said than done. So here's Kelly first on the left.
Thank you very much. and Dr. Grill for your clarity. If lifestyle changes can help 45% of people, what about the other 55?
What about the other 55%? Okay, it does not mean that the other 55 is due to genetics. It just means that we have not identified other factors yet.
Natalie's over here.
What are examples of dietary measures to be taken?
Does anyone know nutrition for brain health?
Very good.
Mediterranean diet. Mediterranean diet has been shown in multiple studies to help with the brain. Basically, a plant-based diet. Cut out the sugar, cut out the junk food, stay with plant-based diet, Mediterranean diet has been shown.
Kelly's got over here.
Hi, thank you. I just had a question. I noticed your 14 lifestyle factors, but I noticed that high cholesterol wasn't on there. Is having high cholesterol, does that put you at risk for getting dementia?
As Dr. Grill has pointed out before, that poor circulation, right, vascular issues increases the risk for poor cognition and poor memory. You'll notice that the risk factors for a heart attack, blood pressure, cholesterol, diabetes, lack of exercise, obesity, they're part of the 14 on the list. If you are at risk for a heart attack, you are at risk for Alzheimer's disease. So the opposite is this. If you want to lower your risk for Alzheimer's, simply lower your risk for a heart attack. So specifically, your question, LDL cholesterol. In a published paper, how many of you guys know your LDL numbers? You, not enough. How many of you guys know your cholesterol numbers? So the LDL cholesterol is the what, good or bad? The bad, right? So you have an LDL of around 130 compared to somebody with an LDL of, let's say, around 70. The person with an LDL of around 130, if you're only looking at LDL, the person with an LDL of 130 has around a 30% higher risk of Alzheimer's than the person whose LDL is at 70.
I think we have time for one more question with Kelly here in the center.
Yes, I was wondering if you could give us some examples of the best types of exercise as well as the role of alcohol. Thank you.
Best type of exercise. As primary care physicians, we typically recommend at least 100, they say 150 minutes a week, but I don't know who's actually counting 150 minutes a week of cardio aerobic exercise. I tell most of my patients 30 minutes a day. Do something to get your heart rate up. 30 minutes a day, because if you're getting your heart rate up, what are you improving to your brain, guys? Blood flow and circulation, right? Oxygen, things of that sort. So that's important. The other thing that's not talked about a lot is the importance of strength training. Strength training several times a week has been correlated also in reducing risk of dementia and improving brain health. You don't have to bulk up, and do weights and things of that sort, but sometimes resistance bands and things of that sort are also very important.
I know Dr. Trinh well, and I know that he has a thing that he likes to do at his talks. Should we?
Sure.
So Dr. Trinh likes to get a selfie with the room, and that he posts it on LinkedIn. So if you're on LinkedIn and you want to follow Dr. Trinh, we can. Can I get in at
Yes,
this
of
time?
course, Heather. Come on in.
So there we go.
Okay, guys, wave. Perfect. Got a picture.
Okay.
Take care.
Awesome. So thank you, Dr. Trinh.
Hello, I'm Dave. Happy Saturday. So we're going to give a brief overview of some of the diagnostics. And I looked over all the slides of everybody. And there's some duplication, and the duplication is okay. There'll be some material that's not covered elsewhere. What is dementia? We are still working with a definition that is almost 15 years old, but it's held up very well. Dementia is an acquired chronic decline in cognition that is not explained by delirium. Delirium is an acute confusional state that older people tend to get when they get an infection or other things and they're in the hospital, or a psychiatric disorder in two of the following domains: memory, reasoning in complex tasks. This is what we call executive function. It's the kind of stuff you do every day, these decisions that you make in your life every day. Visual spatial, language, and personality. Notice, memory is not a requirement. And some people can be pretty far advanced into dementia without having much in the way of memory loss. And there have to be two domains. And then there's a big and. And the big and is they have to be sufficient enough to interfere with daily life. They have to get in the way. And this is going to be important in a few moments. We talk about the difference between dementia and something called mild cognitive impairment. Detection. So there's two ways dementia is detected. The first, and you've heard a little bit about this already, is screening. And screening, by definition, are people who don't have complaints, but when you start posing questions to them or looking under the hood, you find something wrong. These are short. There are at least 8 or 10 of them that are readily available and quite accurate in detecting that something is wrong. It's part of the annual wellness visit, and they're going to actually standardize that to a couple different tests. And increasingly, we're seeing a lot of entrepreneurs and academicians developing computer-based screening for dementia. However, all they do is raise the suspicion for dementia. They don't confirm the diagnosis, and we'll get to that in a few moments. The second way in is memory complaints. So either people voice memory complaints themselves, or at least in my practice, it's much more common that a family member will tell me that there are memory complaints. So I'll tell you an example of a patient of mine who was a CEO of a Fortune 500 company. This is somebody who most people in this room, almost everybody, would know the person's name. And he was a genius. He probably started out with an IQ of 160, but his family noticed he wasn't as sharp. And indeed, when he had more invasive diagnostic testing, he sure enough had dementia. By 3 or 4 years later, he looked like everybody else with end-stage dementia. Making the diagnosis, going from the screening process or memory complaints, requires a clinician's examination. And the clinician's examination needs to get additional history about when these complaints started, what kind of symptoms are happening, because that can point you in the direction of one cause versus another cause of dementia. Whether there are behavioral problems, agitation, irritability, those kind of things are incredibly important as the disease unfolds. And what the person's functional status is. Because as we mentioned, if somebody does not have impairment of function, it is not dementia. I always like to do a neurologic examination and basically kind of the gait and balance. And I also like to look, because indeed some of the dementias may present with Parkinsonian symptoms, and conversely, people who have Parkinson's disease can develop dementia. But the most important is the mental status examination, because this is what's going to determine whether somebody has dementia or not. And here, and I do this in all of my examinations, in fact, all my new patients get this, a memory test, generally more than a screening test. One of the ones that I like to do is I like to, for the generation that I'm seeing now, I'm a geriatrician, what happened to President Kennedy? Assassinated? Where? Dallas? Who shot him? Lee Harvey Oswald. What happened to Oswald? He was shot by Jack Ruby. And those of us who are of that age or older remember probably exactly where you were when this happened. So here you want to have, for these remote things, you want to have something that you know that they experienced. I'll also ask about 9/11. I'll ask about the Challenger shuttle. I'll ask what happened on December 7th, 1941. I also like to do more recent or immediate recall, give them 3 items. I also like to give them a current event. So, I would say something like this. A couple of days ago, there was something that happened in Utah. Yeah. And if you're in the United States right now, you know what that was. Language. So here, there are a couple different kinds of language tests. The one I like is the animal naming test. I send my patients to a zoo or a farm or a jungle, and I ask them to start naming animals. And normal is about 18. If you're getting less than 10 or 12, there might be a concern there. And indeed, people who have Alzheimer's disease will frequently recycle the animals. They'll say a horse, an elephant, a gorilla, a monkey, a horse. They'll recycle them because they don't have a lot of language left. Problem solving. So this is that executive functioning, that reasoning. I'm going to send you to the grocery store and I want you to buy bread for me. Bread is 75 cents a loaf. I want you to buy 2 loaves. I'm going to give you $2. How much change do you get back? They get that right, 50 cents. And then I'm going to send them to the fish counter, and I want them to buy fish, $8 a pound. I want them to buy a half a pound. I'm going to give them $5. How much change would they get back? Next is the clock drawing test. And the clock drawing test, who knows, the next generation may not even know how to do this anymore. Who knows? Anyhow, clock drawing test is you draw a circle, you ask them to put the numbers in the circle, and then the hands. I generally use 10 to 2. And what you find is it is a twofer. You get visual spatial, and you also get planning. So people get into trouble because they've used up all the numbers, and they've still got this area between 9 and 12 that's wide open, or consequently, they run out of space. So it's a very helpful test. Now, this doesn't take me very long. I can get all this done in about 10 minutes or so. And I would say probably 80% of the time, I lead that 10-minute exam and I know whether somebody has dementia. But it's not 100%. And if I can't make that diagnosis, generally the thing I do is refer them for something called neuropsychological testing. And this is different. This is kind of like my examination on steroids. Instead of being 10 minutes, it's like 2 to 3 hours. And they give them really curveballs and splitters and all sorts of stuff. Nobody in this room can get 100% on those neuropsychological testing because they've got figures that you have to be an architect to draw. So they basically dial it up, and it's very helpful in pointing out where the deficits are and how severe they are. Lab tests. And the first reason we want to do lab tests, and these are generally simple blood tests, to exclude conditions that may look like dementia but aren't. So for example, somebody has very low thyroid. This just happened with one of my patients. The cardiologist put her on a drug that occasionally can lower thyroid, and within a month or 2 of being on this drug, she looked like she had dementia. Replaced the thyroid, and she looked much better. So these are simple tests of kidney function, liver function, blood counts, thyroid tests, B12. They're very common tests. Neuroimagings and scans. So these include a CAT scan, an MRI test, and the American Academy of Neurology recommends one of the 2 of those. Actually, the MRI test is a little better because you get a better view of the blood vessels of the brain. But there are other scans that are available as well. One is called an FDG glucose scan, and that actually looks at the metabolism that's going on in the brain. And under certain circumstances, Medicare will cover that now. There's also an amyloid scan, which is used primarily to determine if you're going to use drugs aimed at amyloid, but you can actually get it now through Medicare. It's not that I'd recommend it for everyone, but you can get it. And then back in the closet, there is also something called the tau scanner. And the tau scanner is recent in the back of the closet because it's not commercially available, but it is being used for research. Spinal fluid testing. So spinal fluid testing, there's a lot of very interesting markers. We're going to talk about those in just a moment. But the trend is moving sort of away from spinal fluid markers. And the reason why are the blood-based markers. So if somebody comes up to you and says, Doc, what's the difference between Alzheimer's disease and dementia? And this is a slide that I borrowed from, I was given permission to use from the Alzheimer's Association. Been using it for about a decade. And the way we term it is the umbrella term is dementia, but the biggest gorilla under the elephant is Alzheimer's disease. And typically what you'll hear is 60 to 80% of dementia is due to Alzheimer's disease. And there are other forms of dementia that we won't talk about too much right now. But the problem is, that's not exactly true. This is a study from Chicago, and it's a very interesting study because what they did is they took a look at people in life and determined how severe their dementia is, what type of dementia from clinical features, and then they died, and all these people agreed to have their brains looked at. And what you see is this little gray slice of the pie that says AD on it. Those are people who have pure Alzheimer's disease. And in fact, the vast majority of people who have dementia have more than one type of cause to it. So on the multiple choice question or the open-ended question, what is the most common kind of dementia? Mixed dementia, Alzheimer's plus something. All right, we're going to talk about Alzheimer's disease very quickly. And this is really important because at the same time that the NIA, the Alzheimer's Association, came up with a diagnosis of what the criteria are for dementia, they also started thinking more about Alzheimer's disease. So in 2011, they staged Alzheimer's disease into 3 categories. The first is before clinical symptoms occur, and this would be defined by biomarkers. Biomarkers could be scan biomarkers, they could be blood biomarkers, they could be spinal fluid biomarkers, but something we can detect. The second stage is MCI, or mild cognitive impairment. Here, that there are findings of abnormal brain function on a clinical examination, but function is intact. So there's something going on, but it hasn't progressed to the point of dementia. And here, biomarkers may help and determine whether people are going to progress or not, but also, and you'll hear more about this later on, is whether they might be eligible for new medications. And the third is dementia. So dementia is when you have actually damage to the brain cells. So you have not only objective findings on your exam, but you also interferes with functions. This is a great analogy here. Anybody ever heard of coronary artery disease? It's the same thing. So the first thing that happens is atherosclerosis. It's high cholesterol. That's equivalent to the preclinical markers. The second is atherosclerosis, the plaque that's on the arteries. Okay? That's equivalent to the MCI. And the third is the dementia, which is equivalent to having a heart attack or a stroke. In 2018, another wrinkle was added, and as the picture is unfolding, and the ATN network was published. And this has 3 stages. A is for amyloid, and you all have heard a lot about amyloid, which is a protein that basically is kind of clipped in the wrong places and can become toxic. This is the most important thing you can hear from me, is that up to 30% of people who have normal cognition can have amyloid. Okay? Dr. Kremen, who you're going to hear from later, calls it standby amyloid. You know, it's just there, and it's not necessarily doing anything. And that's really important because you have to understand that to understand everything else. Tau is the second protein, and this is kind of, once again, proteins that are accumulating in ways that they shouldn't, and these actually cause what they call neurofibrillary tangles. Now, if you have tau in your brain, and you have these tangles, you have Alzheimer's disease. And the third level is the neuron is affected, that's the brain cell, and it is either injured or completely gone. With these markers, this is very interesting. You've seen the slide, and you're going to see it again, but in a different format. This happens to be spinal fluid, but what's really interesting about this is the time of diagnosis, you know? And these are years, not months, not weeks, years. And the earliest changes, these are the amyloid, occur 15 to 20 years before anything is going on that anybody can tell. And indeed, that second one, the tau, about 11 years, okay? And then if you screen for them, or you can detect things a few years earlier, but all this stuff is happening when we're in our 60s and 70s. All this action is happening in our 60s, and we're still working. Big news here is there are commercially available tests in the blood for dementia. And indeed, if you are so inclined, I would not recommend it, is that you can get an over-the-counter test called the AD Direct for $412. It is basically $399 for the test, $13 for the reading of the test, and I would not recommend it. It's not the best of the tests, first of all, in terms of the test characteristics, but the real question is, what are you going to do with the answer? As we heard earlier, all of these tests, everything I'm showing you here, is testing only for amyloid. And 30% of normal people have amyloid. So this is really, in many senses, giving you information you don't want to know about. And if you're really interested in these tests, actually, Lumipulse was just approved by the FDA in May of this year. It hasn't been marketed yet, but it will be. There's a couple websites there. It's in your handout. You can go to them. They've got all sorts of great information. There is a new test that has just been developed, not commercially available, that measures actually tau protein, the one you have to have for Alzheimer's. And even though many of these are called tau in there, they're really basically measuring amyloid. When to measure these blood-based biomarkers? They should not be obtained before a comprehensive evaluation. And I've heard some real horror stories. The worst horror story I've heard is that people have gone to health fairs and had these tests done. And you have a test done, and the test isn't all that great, and it's measuring amyloid. What are you going to do except spend the rest of your life worrying? They should not be done in the absence of symptoms and absence of an evaluation. But they can be valuable. They can be valuable mostly if the clinician says, geez, I've done this examination, you maybe had neuropsychological testing, and things are not right here. We think you have dementia. And here, doing one of these tests may help determine whether it's Alzheimer's disease or maybe a different cause of the dementia. So I'm going to conclude, the diagnosis of dementia is based on a clinical evaluation. There's no test that you're going to take that's going to tell you that you have dementia. It's a clinical evaluation. Blood tests can be used to rule out other causes of cognitive impairment. Remember my patient who had the thyroid problem? Imaging tests, spinal fluid, and blood-based biomarkers can help identify the cause of dementia, but are not helpful if somebody has normal cognition. And finally, this is a rapidly developing field. I was at the Alzheimer's Association International Conference a few weeks ago, and I was just blown away. Because 10 years ago, all of this would have been science fiction. And so much progress has been made. And I have to give a lot of the credit to our federal government for investing in Alzheimer's and other dementias. I truly believe, and it's paid off, and looking forward to hopefully having continued funding for Alzheimer's and related dementias.
So I see Natalie in the back.
Hi, I was wondering if tau can actually happen without amyloid happening first?
So the answer is yes. It can. It's uncommon, but it can. There are some cases of people who are amyloid negative, tau positive.
Right here? Okay.
I'm interested to hear your comments on the connection between Alzheimer's and brain strokes.
This is a great question because it really relates to that mixed dementia. Many people have both. They have Alzheimer's disease and also have had strokes. So as we heard from an earlier speaker, you want in your prevention approaches to try to prevent both. We do know that reduction of cardiovascular risk factors, particularly blood pressure, leads to lower rates of Alzheimer's disease, dementia, or mild cognitive impairment. And we now know from the Pointer study that people who are at risk by taking steps towards preventive medicine, managing heart disease, exercising regularly, mind diet, and cognitive stimulation actually show some benefit in cognition. It was not a dementia study, it was a study about cognition.
Okay, and I think we have time for one more study. Steve is over here, straight to your back.
Is frontotemporal dementia the same disease process as Alzheimer's, but in other areas of the brain, or is it a different disease process?
Different disease process. It's got, in fact, it's interesting because some of the drugs that work for Alzheimer's disease, not the new drugs, but older drugs, don't work because it's a different neurotransmitter involved. Now, that said, sometimes it's very difficult to distinguish between frontotemporal degeneration and Alzheimer's disease because there are variants of Alzheimer's disease that involve the frontal lobes a lot. But by and large, FTD is a different disease.
Kelly is over here.
Just wondering about the risks of general anesthetic.
There aren't great data on that for dementia. There are much better data on anesthesia for developing delirium. And there was a study not too long ago that showed it really didn't have that much difference whether you had general or you had regional or local anesthesia. The surgery itself was a big deal. But not great evidence that anesthesia itself will cause dementia many years later.
Okay, and we actually do have time for one final question for Dr. Reuben, over here on the far left.
I was wondering with the diagnosis process, my wife received it this year and she's 54. So this started off as questions about menopausal brain fog and things like that. And I'm wondering why doctors aren't thinking of this or questioning this sooner. We've been working with a neurologist since August of last year, still trying to get lecanemab if possible. But it's HRT, and which of course could be good for the brain as well. And so if this is happening so soon and someone gets it in their 50s, why are we not suspecting it far sooner?
So the story is, if somebody has memory complaints, it doesn't matter how old they are. They deserve an evaluation of memory complaints. Okay. Screening tends to not occur in people who are less than 65 because the yield is much less. About 3.5% of people 65 to 69 have dementia. So when you start lowering the screening age, it winds up getting much less yield. On the other hand, if you have cognitive complaints, yeah, you need to be taken seriously. And in fact, for example, frontotemporal degeneration most commonly affects people in their 50s and 60s. We can't just blow off people because they have cognitive complaints and they're young. You have to take these seriously. I remember caring for somebody who owned a chain of department stores, a worldwide chain of, actually they were malls, and he was in his 50s, and he had cognitive complaints, and we went the whole way, and it turned out he was okay. It was lifestyle issues, and he was taking too many red eyes and drinking too much, but it was worth the workup, yeah. And his family was very grateful.
Please help me thank Dr. David Reuben.
Thank you.
So I'm talking to you today as a practicing neurologist. I'm the director of the Alzheimer's Disease Research Center, but right now our group at USC is treating about 150 people with amyloid targeting therapies. Can you remember AT&T? These are the first disease-modifying medications that we have for Alzheimer's. What does that mean, disease-modifying? Well, how many of you have heard of the medication donepezil? Okay. It's the same as Aricept, right? It's a generic name and a brand name. And then there's several other sisters in that, like rivastigmine is Exelon. How many of you heard? That's another one. Okay. Galantamine or Razidine. Yeah, most of us go with one of those three sisters. Then there's a brother who works differently, Have you heard of memantine or Namenda? Okay. Those are the medications we have for memory and cognitive changes. You also hear about antidepressants for anxiety and depression, and then other medications for agitation. But all of the medicines we have so far treat the symptoms, so we call them symptomatic. They don't treat what we think is the underlying pathology or disease process. They don't treat amyloid plaques or neurofibrillary tangles or neuroinflammation. So I'm going to tell you about 3 new antibodies against amyloid that clear up amyloid from the brain. And so this is the first time we have a disease-modifying treatment. But they're only partial because they don't address the tau neurofibrillary tangles, at least not intentionally, and they don't treat the neuroinflammation intentionally. It's just like a start. It's like the camel is starting to poke its nose into the tent. So this is a picture from 1907. Dr. Alzheimer described the brain pathology from a woman who he had been following from her 50s, very young, early onset. She had memory loss and reasoning problems like Dr. Reuben described, troubles with language, and also a lot of behavioral problems like paranoia and suspiciousness. And after she passed away, he looked at her brain, an autopsy, a neuropathology examination, and he found some new things that were never described before. Some smudges that he called plaques, and some little skeins that look like tangles. And we know that these occur at the connections between nerve cells, the plaques, and inside nerve cells, the tangles. And we know now that the plaque has many things in it, but one core protein there is called beta amyloid. There are many amyloids. It's just a way a protein folds, but the one that's found in Alzheimer's is called beta amyloid. And then the neurofibrillary tangle is made up of a different protein called tau. That's a Greek, like you've heard of sororities, fraternities, okay? Tau actually is abbreviation for a protein called microtubule associated protein tau, MAPT, and that tau protein gets phosphorylated at many places, and that phosphorylation makes the protein sticky to itself, so it forms into a tangle. So both the beta amyloid forms stickiness and forms into a plaque, and the tau protein gets sticky to itself and forms into a tangle. You might have heard when I was up here before that we couldn't diagnose Alzheimer's disease except with an autopsy. How many of you remember that? Okay. Well, thank goodness now with science, like in the last 40 years, we were able to find the traces of the amyloid in the spinal fluid. And same with the tangles, the tau protein, we can see it in the spinal fluid. So get ready, bend over, curl up, and get a spinal tap. I call it a maple syrup tap. But we not only need to get it in the spinal fluid, we can do it with a PET scan, positron emission tomography. It's not a CAT scan, it's a PET scan. It's called positron emission tomography. The chemist can make a tracer that goes to the amyloid, and it's tagged with a radioactivity that the PET machine, the positron emission tomogram, can map. Here in red is a amyloid PET scan. This is a control, a normal person, and all this red here is binding to amyloid plaques. Now the chemist can also make a tracer for the tau protein and tag it to a radioactive tracer, and it will also look red because that's the tag. But it's going to have a different pattern because the tracer was designed to find the tangles. And the tangles really affect the memory center. It's a different sort of pattern. This is an MRI, and it shows atrophy in our brains. This gray here, it has mountains and valleys. It has reservoirs with that spinal fluid that I talked about, that you can lean forward and get a sample. It goes all the way from the brain, all the way down the spine, around the spinal cord to a sac at the bottom below the spinal cord. There is a sac, and that's where we get spinal fluid. But the spinal fluid is here around the brain and in these reservoirs. And when the brain shrinks from neurodegeneration, you can see the gray brain is smaller and the water spaces in black and in the reservoirs get larger. This is the memory center of the brain, the hippocampus. It's only 0.5% of brain volume, and yet it is why you're here today, to learn something. If we didn't have a hippocampus, we wouldn't remember this event or the information in it. Now, you've seen this diagram before. It's showing the order in which we think things happen. On the left, we see that the amyloid plaques start first, then the neurofibrillary tangles, then the memory loss, then the dementia. So we have found from amyloid PET scans that the amyloid plaques start to develop 15 years or so before there are symptoms. So actually, I think we can live with a fair amount of amyloid plaques for those years, and we don't know. It provides a window so that one day we may be able to intervene before there's symptoms and prevent Alzheimer's. Now, we've made, in the last 5 years, another major progress. We can measure amyloid and tau in the blood. So we don't need to have an autopsy. We don't need to have a spinal tap. We don't need to have a PET scan. We can have a blood draw. Wow, that is amazing. So we have made huge progress in diagnosis. What kind of progress have we made in treatment? What I'm going to tell you about is a breakthrough in these treatments, but we're just breaking the sound barrier. So this is a test approved by the FDA, but if you get it, it takes a good expert to interpret it. It's confusing when you get that, but it's there, it's available. We don't know how much it's going to cost yet. I order it, but I don't think we know how much. It's going to be in the couple hundreds of dollars maybe. Now, another thing I want you to be aware of is the genetics of Alzheimer's. This is a nice graph showing about 40 genes or variants of genes that are associated with an increased risk of Alzheimer's. And the number of them keeps going up every few years that this paper comes out. It was 20, and then it was 40, and the last time I read it was 78 different variants can increase the risk of Alzheimer's. There are very common genes over here. This axis here means they're very powerful risk factors. So these most common ones don't have a lot of adverse effect, but some that are rare can have a very powerful effect, and these are mutations. How many of you seen the movie Still Alice? Okay, so this was a professor, 50 years old, who had trouble remembering her lecture and finding where she was running, jogging. Well, it's a picture of physical and mental exercise, but she's carrying a genetic mutation, and the symptoms were beginning in the 50s, kind of like Alzheimer's patient. Those are really rare, fortunately. But the one that I want to tell you about today is apolipoprotein E, ApoE for short. Here it is, ApoE. It's pretty common, and it doubles the risk of Alzheimer's twice. So in this room, about 25% have this. So you're in good company, okay? And about 5% of us here in this room have this. And this one increases the Alzheimer's 10 times. And ApoE4 increases amyloid in the brain. And actually the effect is a little bit more so in women than men. There are 3 antibodies monoclonal antibodies, designer antibodies that can find the beta amyloid. These three have been approved by the FDA. They're called aducanumab, lecanemab, donanemab. And once they're approved by the FDA, the company can change the name to something more catchy. They were approved in 2021, 2023, and 2024. So these are antibodies. They are immunotherapies, immune system antibodies. They lead to a dramatic reduction in amyloid plaques. We call them fibrillar deposits of brain beta amyloid. They have a very modest slowing of cognitive decline, but they have an increased risk of vascular-related side effects called ARIA. You know, it has nothing to do with opera, but it's easier to remember. Yeah, okay. Amyloid-related imaging abnormalities. The people who are appropriate to receive these therapies in terms of their diagnosis have mild cognitive impairment or mild dementia, you know what those terms mean now, due to Alzheimer's disease. Now, how do we know it's due to Alzheimer's disease? There needs to be a positive amyloid PET scan or spinal fluid studies showing the amyloid or the tau proteins. Persons should be in this age group and have a mini mental state exam of 22 to 30, a partner to support the treatment program, and the ability to understand the protocol, what's needed, and the potential benefits and risks. There are also a number of things that would increase the risks, and these would exclude people from getting the treatments. If there's a lot of vascular, like stroke or other vascular injury on an MRI, person is taking anticoagulants, which could increase bleeding. Person should not get TPA for if you have a TIA, a stroke, unstable medical conditions, and mental illness that would interfere with comprehension and compliance. Okay, so this is a figure from aducanumab, the first antibody that was approved, and this shows in red here the amyloid plaques from an amyloid PET scan. And this is a little bit of a cartoon. This is the baseline, and this is 1 year later, a repeat amyloid PET scan. There's this group that got placebo, which is, they really didn't get the antibody. They did not get the treatment, but they still got the IV with salt water, saline. They didn't know what they were getting. This shows a group that got a low dose or a higher dose or a higher dose yet. And this shows what happens. This is, when it's going up, it means their dementia is getting worse. So the placebo group, say over 1.5 years, got worse compared to the treatment groups where they didn't get worse. Somebody must have passed away and kind of give us an insight of what's happening. The red color here is an amyloid plaque, and the brown here are little garbage collectors in the brain. They're called microglia. And this treatment, the antibody attaches to the amyloid and signals in the garbage collectors to come and remove the plaque. And so looking with this medication, what happens to the plaque? Do you see it's going away? So this is why we call it a disease-modifying medication. This is a graph from the second antibody, lecanemab or Leqembi. This is a placebo group with multiple PET scans, no change in the amount of amyloid, and this is what happens to the patients that get the antibody, lecanemab, which is Leqembi. Look what happens to the plaques. They're like 80% cleared. That got us all excited, but what happens to the person's memory and thinking? That's the data here for lecanemab and for donanemab. Leqembi or Kisunla. This is over 18 months of treatment. The blue is the decline in memory and thinking that occurs in the placebo group that had all the IV treatments but no medication. And this is what happened to the participants that got the antibody. There was a 20% slowing in the Clarity treated participants with Leqembi. And with the other medication, the third antibody, it's a very similar picture. It was 29%. I think they're virtually the same over 18 months. That's the benefits, okay? What are the side effects? Okay, that's where the ARIA comes in. The ARIA is the side effects, and we can see them on the MRI, and they can be found in about 20 to 30% of people that get these treatments. What is ARIA? They stands for amyloid-related imaging abnormalities. ARIA, amyloid-related imaging abnormalities. The I is the MRI. These are MRI scans. It can look as either these white things, which is just water swelling in the brain. It's not a stroke, it's water. It's edema. We talk about ankle edema in heart failure, okay, so it's edema, but it shows up as this white in the brain. We call it ARIA-E. And there can also be some small bleeding, and that sounds terrible, so I have to say small bleeding. It could get big if someone was on an anticoagulant, okay? That's why we don't treat people with these medicines who are taking anticoagulants. But it can have a small bleeding, and we call them micro bleeds or micro hemorrhages. And we can see them as little black dots here. Or on the surface of the brain, we could see the bleeding here as a black little thing in the spaces, the valleys between the brain. So we call this ARIA-H. And we can look at how frequently these things occur for lecanemab and donanemab. They occur a little bit more frequently in donanemab than lecanemab. And we can look within each of these groups for those who have ApoE4. Do you remember that ApoE4? 1 copy or 2 copies. If a person has 1 copy of ApoE4, the risk of ARIA doubles. If someone has 2 copies of ApoE4, that would be like 5% of the people here, it goes up 6 times. So many of us actually don't feel it's good to treat people who are carrying 2 copies of ApoE4 with these medications. So before going into this treatment, we would want to know your ApoE type. So this is the treatment protocol for Leqembi at USC. It's a 1.5 years. The treatments are every 2 weeks. So for a 1.5 years, 18 months, this is a Dr. Reuben test. It's 18 months times every 2 weeks, so it's at least 36 treatments, but you know, a month has more than 4 weeks, so it's actually 39 treatments. Okay. And we have to get an MRI. We have to have a PET scan at the beginning. We get a PET scan at the end, and usually these show a significant improvement, the amyloid PET scan. We need to get an ApoE genotype, an MRI. We call them surveillance MRIs. We're trying to detect ARIA, because although I mentioned ARIA occurs maybe in 30% of people, only about 5% have symptoms. So with the MRI, we're catching things early. And when we see the ARIA on the MRI, we have to adjust. Maybe we'll stop the medication. Maybe we'll stop it permanently. But the MRI is very important for safety. And this is the protocol for Kisunla. It's given every 4 weeks for 12 months, so it is 12 treatments. Instead of 39 treatments, it's 12 treatments. So most people would go for that, but the risk of getting ARIA is a little bit higher with the second medication, so there's a lot to consider. Okay, so what are the pros of these antibody treatments and what are the cons? The pros, okay, we have a first disease-modifying treatment. You know what that means? It reduces the amyloid plaque by 80%. It slows the symptoms by about 30%. Now, what are the cons? The cons are you can have ARIA, and it's about 30%. Okay, but it's maybe 5% that have symptoms, but still, I really don't want to have ARIA, right? It doesn't sound good, all right? And the cost, what is the cost? You have to go in for 39 treatments for lecanemab, and you have to go in for 12 treatments with donanemab, so it's over $100,000. So when aducanumab came out and Medicare didn't say what it was going to pay, and I only have one person that could afford that. But Medicare does pay 80% for the right people. But if it's not Medicare, it's a lot harder for us to get coverage. If you have Medicare and a secondary insurance, the secondary insurances are pretty, we don't have any problem. They'll pay the 20% if Medicare is paying the 80%. The treatments themselves are probably going to come out as an auto-injector, so you actually won't have to go in for infusions. When do you think that'll occur? Maybe next year, I don't know. Now, all these treatments probably will need maintenance, so after you finish 39 treatments in the 12, we still have to have maintenance, but if it's an auto-injector, that'll be, some people are doing that for migraines already or for other things. Can I just take a poll? Would you consider this? Okay, you can say you're not sure. Okay. Some people would consider it if you want to know more. Okay, I see some show of hands. And how many think it's just the thumb is on the scale over here, too much? Okay, all right. And how many just want to be in the middle and you need to know more, you need to talk to your doctor about your individual, right? Okay, thank you very much.
I see a hand in the center.
I might have missed this. Did you mention in the placebo group the percentage of ARIA that was detected?
Oh, it's about 20%.
The same as the other?
The placebo group, no, I'm sorry. I was thinking about the ApoE negative group, I'm sorry. Yeah, the placebo group is much, they don't have much ARIA.
Nothing was detected?
No, sometimes people will have ARIA on their own, like we'll see people have hemorrhage or, but it would be pretty rare.
Over here toward the left back.
Hi, I'm a high school student studying genetic therapy for Alzheimer's disease, and I was just wondering, do you think this is a viable therapeutic method for specifically sporadic Alzheimer's?
So it depends on what we mean by sporadic. Okay, so this is a treatment for sporadic Alzheimer's. If you have ApoE4, it's considered sporadic. And all those common genes that are increasing, we call them sporadic. The ones that we call familiar have the mutations, and those are very rare. So this is a treatment mostly for sporadic. But it's not exclusive. If people have the mutations, they can also be treated.
In the center here.
Do you feel this medication would have any effect on the death rate from Alzheimer's, people dying from Alzheimer's?
Within the treatment trials, there were a few deaths, like 1 or 5 deaths. The treatment, how much was it due to just natural death versus, I think there were a few cases where it was related to the treatment, and they were kind of published case reports. So I remember one who had 2 copies of ApoE4 and was on a blood thinner, and there was hemorrhages.
Thank you, Dr. Chu.
First of all, thank you. You guys are brave. And what we'll do is start with a round of introductions. Basically, your name and how you learned about clinical trials in general, or what clinical trials you're in, or what clinical trial you were in.
My name is Deborah Lindberg. I live in, believe it or not, Madison, Wisconsin. Just moved from Redondo Beach. Backwards.
Why?
I was very, very fortunate to have Dr. Trinh help me through the trial for donanemab, and it was a wonderful experience. He and his team are unbelievable, very caring and knowledgeable, and it was always fun to be there.
This is not script. No.
It's not. It's not.
Just kidding.
But they do a wonderful job, and we miss them very much.
My name is Sydney Singer. I go with her. And as you heard, we did move to Madison, Wisconsin 4 months ago. Deb has family there, and we felt it would be a good idea to be close to family at this point. Deb did participate in Eli Lilly's donanemab trial, and just as she was finishing the trial, we're happy to report, as you saw, that donanemab was approved by the FDA and Medicare, and that is huge, because let me tell you, Deb did so well. It is unbelievable, and Dr. Trinh, of course, with his wonderful Healthy Brain Clinic staff, they did an incredible job, and we're very, very fortunate to have been in that trial, and now it's legal. Anybody can get it. No, not quite, but so thank you.
Good afternoon, everybody. My name is Mark Ammons, and the way that I found out about it is there was a seminar or an outreach at the Missionary Baptist Church in Yorba Linda, and this group was represented over there, and one thing led to another, and I found my way over to Dr. Trin's place, and it's one of the best feelings that I have. Great work he has there, great workers, everybody's friendly and kind. I don't run away from going there, I run to go there because I feel so much better after I leave. And I think he's done a wonderful job, not just for me, but for a whole bunch of people. By the way, everybody conducts themselves friendly, kind, but they take care of business that needs to be taken care of. And my wife and I have been going for a while, and we are blessed to have run into that place and to the doctor.
I'm Karen Ammons. I'm the other half, and I have been familiar with clinical trials before we met Dr. Tran. I used to work at Keck School of Medicine, and so I participated in several of their clinical trials there. So when they came to my church, it was an opportunity. They had a booth there and said that, you know, if you wanted to participate. So I thought about my husband for that. And it has been a great experience for both of us as caregiver and as actual patient. And so, you know, I'm 100% sold for clinical trials because you're not only doing something to perhaps help your person, your family member, but also your community. Okay, thank you.
Hello, everyone. It's good to be here. It's good to be heard. My name is Lupe Morales. I'm a native of Los Angeles. This is what natives really look like in Los Angeles. I'm happy to be here. I learned about clinical trials, sadly, not by my mother's doctor. I'm her caregiver. I have been for years. I actually went and found a friend of mine who is the director of aging for Cal State LA. And eventually, I got to a neurologist, and she told me a little bit more about clinical trials and introduced me to a recruiter. I began to speak to a recruiter about my mom, and I joined, not so much for myself, although I'm here because of myself now. I joined to see what it would take to get my mother through one. So I'm happy to be here.
What is it like during the initial enrollment period of coming in for your first visits and all that. And what is that process like? Because there's forms to sign and consent forms and all that. What is that like?
I thought it went very well. I think Ashley was there when we first started. And it was very informative, and I felt safe. It was very good, I thought.
I agree. It was streamlined, but we were given all the information that we needed to fully understand what we were getting into. And then when we read over everything, we felt very comfortable about getting involved in the study. And I forgot to just mention, we also want to thank Alzheimer's LA, because as you may or may not know, they have the early memory seminar, and that's when we first met or heard of Dr. Trinh, who explained why it's so important to be involved in medical trials. So if it weren't for Alzheimer's LA having us meet Dr. Trinh, who administered the Eli Lilly drug, we wouldn't be here today.
I think Dr. Trinh is an outstanding person and skilled, and he puts people around him that have the same spirit. And so when you come to a different place and you don't know what's going to happen, if you're in his place, you're going to feel comfortable. He picked good people around him, people who are encouraged, so that when you left, you feel better than when you came. I just think he's an outstanding person and has set up an outstanding organization there, and I can't wait till I go back again.
I think the experience is so much different than going to a medical doctor, because a lot of times they really don't help you sometimes. You see your general practitioner, they have to diagnose so many different things. It's not their specialty. But being sent to a place where someone understands and gives you the time, we saw a neurologist under our medical plan, but they just deal with the diagnoses and just basically send you home kind of a thing. And with what the clinical trials does is they ask you how the person has behaved within the last time they saw you, any concerns that you have. And so a lot of times it's just knowing you're in a place where someone is helping you deal with what you're going through.
I'll piggyback a little bit on Karen, because not all healthcare programs are the same, and different people get different treatment. You shouldn't assume, and I had to learn that, for example, not all doctors follow research. In my profession, I'd have to go to conferences, certificates, et cetera. One of my learnings was that, those doctors that are both researchers and clinicians, see people in clinic, are the best doctors, because they already have a network and they can refer you. Unfortunately, my mother's doctor, he was good, her doctor for 12 years, but he was unable, did not know, and couldn't send me anywhere. So in terms of the screening process, when I finally did call, there was a woman, a recruiter, who told me a lot about the different studies, and honestly, I was so overwhelmed because my mother was at a crisis state, and so your stress level is already high, and you don't have a lot of more bandwidth. So luckily, it was the woman that we spoke to was a social worker, so she just used her methods to calm me down and to spoon feed me information. She met me where I was and found a study based on questions that she asked to help me. So she got me in to a study. My mother was going to be in a different study, but we decided for me to go first to see what it would take to pull my mother through it. So for me, I was scared. I was in crisis also. I was watching my mom go through certain behaviors that I had nothing about. But I would say that initial period was important to calm me down, meet me where I was, and allow me to have choice at that point.
I'm curious if you had any anxiety any fear, any worries about clinical trials before you ever got into a clinical trial?
You know, it's interesting. Maybe I should have been a little bit, but I just felt really in good hands with your group, your clinic. And obviously, as Sydney mentioned, you know, Eli Lilly is a terrific company, and we feel safe with what we had.
It's interesting because one of the things that concerned me more was that I had watched my mother go through this disease for 24 years, and I saw what it did to her. And that scared me a lot more when we found out that Deb was sick. It scared me a lot more to know that she could end up that way. So for me, going to a medical trial was the safest thing we could do to get involved and do something to stop this. In fact, we went to our neurologist who had treated my mom. And when he saw Deb, his response was, when we told him about the donanemab, he said, "Oh no, you should never do something like that because there's a risk of a brain bleed or there's risking of all sorts of brain swelling. You don't want to do that." And I looked at him and I thought, you treated my mother and how many other patients, and you just let them deteriorate like that. And you didn't want to do anything now for Deb? Why? What I've since decided is that everybody has a different tolerance level. I have no right to judge, but I know for me, I wanted to do something. I wanted Deb to get better. I wish we could have done that for my mom. So it was the safest thing for us to do, is to get into a medical trial, and we're trying to get into more.
This medical trial exceeded my expectation in terms of the kindness, the organization that's there with the proper people around the doctor, and I look forward to going, you know, knowing also and trusting also that the process is set up for me to get better. And so I believe that that's in process, and I thank the doctor and all of his staff for being the persons that they are. Some people just want to get a check. Nobody run into people like that, huh? But this person, in my opinion, is really a kind person and looking out for other human beings. And that is what has stuck with me, and I thank God for that.
I come from a background working at a medical school. So, and I participated in studies there, and working in a lab and seeing that research being done, it was an easy thing for me to say when I saw this opportunity for at this health fair to try it to see if my husband would benefit from that. So I wasn't scared because I'm wholeheartedly for clinical research, because that's the only way cures are going to be found. If we are all afraid of not trying something, then we may, you know, it may not help us individually, but further down the line, since they've done these trials all along, it may help someone else. And that's what my motive of doing this, because you got to try, because if not, the worst case scenario is you just let the disease run its course without any kind of help. So I'm totally for clinical trials.
I'm single, never married, no kids. I was scared shitless. On top of that, again, I say, my mother was in crisis, and that put me in crisis as well. So I had to kind of get over it. And the first portion, like I said, the screening, and the fact that the woman that was recruiting was a social worker really, really helped. What got me over the hump is that I had to really learn slowly and at my own pace about this disease, because my mother was no longer herself. And I wasn't even thinking about myself yet, and that I might be at high risk. It was more, can you help my mom? Right? And so eventually, after I went through the process, I realized that my mother was at the later stages by the time she was diagnosed. And so I had to turn into myself and say, well, am I at high risk? And what does high risk mean? And being alone and trying to find a buddy system. By the way, I'm one of 7 children, but as some of you may know, being in a caregiving situation with a parent can break families, where 1, maybe 2 people are the lead caregivers for their parent, in my case. And so I really didn't have a study buddy, right? Because many times you go in and you have to have someone else with you. And we got around that, but it was difficult. It was a different situation for me. And whereas I would advocate for my mother like a dragon, I couldn't do that for myself.
Final question. What is the most important thing you would want others to know about joining a clinical trial?
I think that it's important that we, look to companies that can find the right drugs, and companies like Eli Lilly and other ones like that. I'd say that's important. That's it. Yeah.
Again, here I'm telling you, I'm trying not to judge. But I can tell you that I always believed when my mom passed away that they would find a cure for Alzheimer's. When my dad passed away from prostate cancer, I thought they'd find a cure for that. We're coming so close for each of those diseases. I've got a lot of friends now who have prostate cancer, and they're living much longer and better lives. And with Alzheimer's now, we have an opportunity to do something that we had never had before. If you believe in helping other people, do it. There are safety protocols that are set in place with all studies, just to let you know. With the study that Deb was in, there were MRIs, as you heard, that were given throughout the study, PET scans that were given throughout the study to make sure that she wasn't having ARIA or any other problems. So just to let you know, the drug companies are very good about that. And my response is, if you have the opportunity, do it.
To me, the most important thing is setting up a solid basis or place to go where patients can feel that they're being dealt with in a proper way. And you have that strong organization that is ministering to the people that come. Not only blesses them, but if they have families, they're blessed because they see that the place that you have chosen was the right place, and that they will say, if I needed to go to a place, I want to go to that place. I found that between me and my wife. We were very pleased with the organization that you set up and how you and your people treat people who are coming in when they're not less than the best, but then they have an opportunity to grow and get healed. And I think that's wonderful.
I think support is the main thing that you should consider if you're considering getting in one of these groups, because it's very difficult to do it by yourself. I know as a caregiver, it's at times it could be very stressful. For the person who's going through this, it's stressful. So just having an outlet where you can go and talk to people who know about what you're going through. And so I think that's what makes this support so good for, if you want to come in. And just, the medical tests, even if you go to the doctor's office, you're still going to have medical tests. You're gonna probably have that most of your life from now on, but it's just knowing that there's someone there who knows what you're going through.
And for me, choice is number 1, partnership is number 2, and that you can get involved in more ways than one. Choice is that there's a variety of clinical trials out there for you. You can test technology, and that's part of clinical trials also, whether gaming or have a device on you, etc. That's number 1. It's your choice. Whatever you feel comfortable with, meet yourself where you are and grow from there. Second is partnership. If you don't feel like a partner in your research trial with a team, then it's probably not the right choice for you. You have information about your body, your experience, and it's really important that they see that you're both learning at the same time. It's our study, because I'm in it now. And the third is that you can get involved at any level. Even if you choose to do a study, I really want to encourage you to look at being part of their community advisory boards or their advisory boards and speak to as many research participants as you can. Now, many trials may not let you do that, but go to their community advisory board meetings and just ask, is anyone a research participant? And speak to someone a little more. So there's a variety of ways to get involved. Go where you feel the most comfortable at this point and build from there.
Thank you. Questions time.
So yeah, questions time. So first of all, this kind of ran like the Dr. Trinh fan club, huh? So I'm a member of the Dr. Trinh fan club, but I also want you to know that I'm a member of the Dr. Kremen fan club, the Dr. Wu fan club, the Dr. Grill fan club, the Dr. Reuben fan club. You cannot find a better group of human beings. I've always said since I came to Alzheimer's LA, it takes a special kind of person to work with our community. And these are special people. And while you've heard about the experience of working with Dr. Trinh, and that was mostly coincidental, that we had 2 people who had been through a trial with Dr. Trinh, I can promise you that you will have the same type of experience with our other partners. And so wherever you're at, if you take nothing else away, we want you to know that you will be safe and you will be well cared for wherever you choose to get involved in a trial. So we're going to take 2 quick questions from the audience. Our panelists are sticking around, and there is going to be a break. I see one hand up here.
I was wondering, do participants ever find out if they actually got the drug or if they're the control group?
There was no placebo.
The experts in the room will correct me, Dr. Trinh, Dr. Kremen, Dr. Wu, but my understanding is that often at the end of a trial, it becomes unblinded, and people will find out at the end. But would you say that's fair? Sometimes, not always. It just depends on the study design. So sometimes you don't know, but sometimes you might find out. One more question. Do we see who's going to get there first as Kelly makes it?
I was curious because you were all positive if there were any people who enrolled in the study who dropped out because of complications. We only heard a rosy side.
Right. The answer is going to be yes. I don't know if I think this might be a better question for Dr. Trinh. Yeah, there you go.
So when you are in a clinical trial, you are a volunteer. You can drop out anytime for any reason. We've had folks who move. We've had folks who their study partner was no longer interested. We've had folks who had to go and get hernia surgery for something different, completely different from the trial. And so yes, the dropout rate is not high, but if you have a trial that's 2 years long, it's very rare that you have 100% of the folks going through the entire trial for 2 years, right? There's going to be a dropout rate. It is low, but in the end, you're just a volunteer. You don't have to stick with the trial if you didn't want to.
Okay, so we're going to wrap up this section. Thank you, ladies and gentlemen.
This is a bit of a little bit of a less popular topic. We're going to just try to do the best we can with it. There's a lot to learn. And who best to show us a little preview about what this topic is of agitation and psychosis, but Anthony Hopkins.
Date of birth?
Friday, 31st of December, 1937.
You're living with your daughter at the moment?
Yes, until she goes to live in Paris.
No, Dad, why do you keep going on about Paris?
You told me.
No, I didn't.
I'm sorry, Anne, you told me the other day. Have you forgotten? She's forgotten. Paris. They don't even speak English there.
Dad, I'd like you to meet Laura.
How do you do, sir? I say, you're gorgeous.
Thank you. I must say he's charming. Yeah, not always. Laura has come round to help you.
I don't need her or anyone else. I can manage very well on my own.
Everything all right?
Who are you?
Actually, it's me, Paul.
Who?
I live here.
What is this nonsense? Anne?
It's me.
Ah, there she is.
Your father seemed a bit confused.
Something wrong?
Where's Anne?
Sorry?
Ma'am, where is he?
I'm here. What's the matter, Dad?
Strange things going on around us.
Don't worry. Everything will sort itself out. Saw it in his eyes, didn't know who I was. It was like I was a stranger to him. Just did something to me.
I don't know what she's cooking up against me, but she's cooking something up.
What are you talking about, Dad?
I'm not leaving my flat! I am not leaving my flat! This really is my flat. Isn't it? You see, the situation is very simple. My daughter is of the opinion that I cannot manage on my own.
I'm so sorry about this.
Why? She understands perfectly.
It's important. I explained it all to you.
Why do you keep looking as if there's something wrong? Everything is fine.
I think she tries to do the best she can for you, Anthony.
Everything will be all right. I promise you.
There's something funny going on.
So Anthony Hopkins starred in this Oscar-winning movie, The Father. He plays an 80-year-old with dementia. He was living alone. He starts to show that he has kind of emotional reactions to the confusion that he's facing, and he starts resisting the help that his daughter is trying to arrange for him. With the power of movie making, they're able to show the perspective of someone who's experiencing the Alzheimer's and what some of these experiences are like, which are, again, confusing about what's real and what's not. Today, we're focusing on agitation and psychosis, but really these are under an umbrella of what are called the neuropsychiatric symptoms of dementia. Neuro meaning that it's coming from the brain. Psychiatric means that it's resulting in changes in behavior and emotions. Okay, so these are separate symptoms from the cognitive symptoms of dementia. So we're not talking about now about memory or language or the executive functioning. The first one we're talking about is agitation. Agitation can be verbal, it can be physical, and it can also just look like restlessness, where people just have trouble sitting still and they have to keep getting up, pacing around. Verbal agitation often is described as verbal aggression, raising your voice, maybe using expletives that you otherwise is not in the context. Maybe again, saying things that you typically wouldn't say in maybe a public environment, but kind of the gates are not there. And so so there's these verbal outbursts, if you will, that can arise. Physical aggression can be resistance. So someone's asking you to do something and you're posturing, you're defending yourself because you don't want to do them. It also can be aggression, meaning throwing something, slamming a door. It can be throwing a pillow. It can be actually punching or pushing or kicking. So there are these different types of agitation. I also want to just define psychosis so that we're all on the same page. Within psychosis, there are two general categories. The first being hallucinations. So this is when someone has an experience involving a sense, one of your sensory systems that that you're sensing, but that's actually not happening, or it's actually not there. So one of my recent patients started hearing her brother call out to her from outside of her house. Her brother lives across the country. So her brother, in fact, was not calling out to her, but she's hearing his voice specifically. And so this is an auditory hallucination. This isn't a hallucination that's involving somebody's voice. There can also be hallucinations which involve just visions. Sometimes they're realistic visions, sometimes they're not realistic. For example, people seeing little animals, in the room that are not actually there. Other people can see, there's a car that keeps driving by, and I keep seeing that car over and over again. These are separate from delusions. Delusions are a false belief that's not based in reality. The most common delusion that we see in Alzheimer's disease is based on a delusion revolving theft. Okay, so there's a false belief that somebody has taken something from me. The root of this, in fact, is actually their memory. They can't find something. They can't find where they put their money. And so the brain is a spectacular thing and kind of can fill in some of the narrative. If I can't find my money, it must be that somebody broke into my house, found my wallet. It can get quite elaborate, or it can just be beliefs. So there's really a gamut of beliefs, but ultimately what makes them delusions is that they didn't actually happen. These neuropsychiatric symptoms are in fact quite common. So across the span of one's illness, over 80% of patients will experience one or more of these NPS symptoms at some point in their illness. Most often we see these occur in the moderate to late stages of Alzheimer's. It doesn't mean that it absolutely cannot happen in the early stage, but by and large, it's moderate to late. There's a domino effect to somebody experiencing these symptoms, and really a lot of it falls onto the caregiver, the recipient of um, kind of somebody who keeps talking about what they're hearing or their fear that somebody has stolen something from them. Whoever is around them is really experiencing the burden of this quite often. And ultimately, when we see kind of big cohorts of the population, we see that this can lead to earlier transition to moving out of the home into a facility. And then there are a lot of costs associated. Again, primarily we're talking about psychosis and agitation in Alzheimer's, but depending on other types of dementia, we see kind of a different prevalence of different neuropsychiatric symptoms. And so in frontal temporal dementia, there tends to be a lot more of something called apathy and or social inappropriateness. So I just wanted to kind of point out that depending on the etiology of the dementia, we might see kind of a different symptom rate. But in the end, there are still a lot of overlapping symptoms. What can we do about it? We're going to kind of shift gears to talking about behavioral strategies. And behavioral strategies are actually quite important, partly because the reality is we don't have great medications for these symptoms. The behavioral symptoms, we want to consider environmental, and then also caregiver focused. So some people might get more or less agitated because either they're overstimulated, there's just too much going on around them, and that's what causes them to be restless. Other people actually are understimulated. They're in fact bored and they're isolated and nobody is talking to them enough. And that's when kind of some of these other ideas really get flourished. We find that daily routines and having high structure in the week really helps people regulate some of these behavioral symptoms. We also want to consider safety factors because if people are very restless and that leads them to wandering, for example, we need to kind of think about then safety measures in the environment. And so again, kind of different strategies to consider for the environment. For the caregiver, really this is kind of what we're doing partly today, is kind of sharing the education of what these symptoms are, what can we do about some of them, and really have the conversation about maybe what works for one person, which might end up working for somebody else. What we find that really simple and direct communication from caregiver to patient is actually the most helpful. That might mean not giving too much choice. So if you're saying, what do you want to eat today? So open-ended questions sometimes actually might be overwhelming in some circumstances, and maybe simplifying choice as, are we going to have pasta today or are we going to have chicken? This is a kind of oversimplified example, but kind of having these direct, simple choices is helpful. Ultimately, we're talking about each and every person, and everyone has a life story that we really need to take in account. And that might include what's been traumatic in their life. It might include, what hobbies they loved and kind of what values they hold. So someone who always loved music, for example, that is something that maybe you would think that you are going to incorporate in kind of your approach to kind of what might be therapeutic to them. And someone who had some trauma at the beach, for example, throughout their life, you're not going to kind of bring them to the beach when they're in a state of confusion, because that's not going to be therapeutic for them. And so kind of really knowing who your audience is and trying to come up with an individualized plan that's going to be therapeutic for them. In terms of what's been studied in research, actually music therapy has the most evidence. We're talking a lot about trials today. These trials are a little bit harder to carry out. If you can imagine, how do you have an active group and a placebo group when for some of these interventions, it doesn't quite translate as well. But just to say that people are looking into different behavioral modification therapies and trying to show a signal about what's helping. And by and large, across kind of big groups, that music therapy has the most evidence. I do find ultimately all these types of therapies are different ways of distraction. And so when someone is in a mindset that is maybe more negative or fixed on something, really we're talking about different methods of distraction. And that might be, let's go for a snack, let's turn on this sitcom, let's give our niece a call, let's go take a walk around the block. We're just talking about different types of distractions. But I do kind of encourage you kind of to think, outside of the box to see again what's going to be helpful. I find that inviting people to join you is one way to kind of distract them from what they're doing. Come over here and help me fold these towels. Doing an activity together is kind of one way to break up a negative mindset or maybe one of these hallucinations. Mirroring activities when someone's having a hard time doing something and getting very frustrated and maybe agitated that way. I'm going to put on a shirt and you put on a shirt and let's button it together. We're going to have some ice cream now. I'm going to have some and then you're going to have some. And maintaining dignity of choice, providing reassurance, and I would also say that you avoid constantly correcting people. It is not always therapeutic to confront people when they can't remember something. And so it's not always about being right or wrong. And it might just be moving on from the topic might be a better approach. We're going to just briefly run through medications. We resort to medications when these behavioral strategies are not effective enough. And behavioral strategies might help in one moment, but then maybe the following week they don't. And so medications are kind of second line to these behavioral strategies. I would say overall, we are in great need of medications that are effective for these types of agitations and psychotic symptoms. Because we don't really have a good menu of medications to choose from, there's a lot of individual discussion about pros and cons. Unfortunately, all of the medications have some cons. And so having that discussion, knowing what the individual health considerations are, again, what something that worked for one person may not apply to the other, knowing that in fact, by and large, these medications are off-label. That means the FDA, that means the drugs were not developed for the use of Alzheimer's in mind. And a lot of these medications have been borrowed from other disorders. For example, other disorders that also experience psychosis. And then we've scaled back the dosages quite a bit in this population. There are also daily medications for these symptoms, and as well as what we call PRN, or as needed. So some of these medications can be just taken once in a while when there's an episode of a delusion, for example. And then some of these medications really are meant to be taken every single day. By and large, the medications used for delusions and agitation or psychosis and agitation are under the class of atypical antipsychotics. There's modest evidence. Unfortunately, there are quite a bit of side effects. Right now, we actually only have one FDA-approved medication for agitation, and that's called brexpiprazole. The brand name is called Rexulti. For better or for worse, you may have seen an ad about them on your TV. Right now, that they're the only FDA-indicated medication. This is in the same family as other antipsychotics, which are kind of listed on this table, just to say they have some pros and cons. They are still all used under different circumstances, and these side effects do need to be monitored. Antidepressants also have been shown to be helpful in agitation. These are medications like Lexapro, Zoloft. They're inconclusive, but overall they're much safer. There's another class under mood stabilizers. Kind of, again, I'm not here to kind of list out each medication, but just to say there are different families of medications used to target these symptoms. Some also, again, some inconsistent evidence. Benzodiazepines are medications which include Xanax or Valium, meant to be very short acting, limited data, and also have some adverse effects. And the last category I wanted to just bring up were stimulants, specifically methylphenidate, which is also used in ADHD, or Ritalin, has been shown to help with apathy specifically. So yes, there are medications out there. The ultimate choice to what to use after behavioral strategies are less effective is really a conversation to be had with your provider. And who might you go for some of these questions? Unfortunately, there's not enough geriatric psychiatrists for everybody. It's kind of hard to be able to find those clinical appointments. But some neurologists are managing these medications for sure. Some primary care doctors are also. Kind of depends on each provider's scope. For additional tools, we're really talking about the community partners, and Alzheimer's LA, we are so lucky to have them as a community partner. Really, their calendar of events is spectacular, and there are a lot of educational educational programs, including specifically one targeted for savvy caregivers, and there's one specifically on challenging behaviors, and they're really a wonderful resource. Really, this is about utilizing your village, and so if that means maybe relocating, or if that means calling in kids to have a meeting about what's going on. Ultimately, it is about how do we figure this out together. At some point, there may be the need to bring in help. So your own ability, this is not about any one person's heroic ability. Caregiving really needs to be shared because caregivers also need breaks. And so bringing in help may be necessary at some point. Day programs for the person with dementia may also be helpful. That way they are in a safe and structured place, potentially a few times a week during the week, and they have stimulation, they have socialization, they have a meal together, and then that way the caregiver can go to their own appointment or get their hair done. We are lucky in LA that there are really a lot of different types of support groups. There are support groups specifically for spouses. There are ones specifically for children. There are different ones for different types of dementia, and so I really urge you to look into these support groups and then lean on them. Everybody helping each other is really important. And then again, asking your medical provider about what else, what are their resources, what else can we do? I think it's really important to have those conversations. In terms of what's next, we do ask you to consider getting involved in clinical trials. Clinical trials actually is not exclusive to people who have symptoms. We really need as many people who are healthy, who are related to people with dementia, who are caregivers. Really, there are trials for everyone. And some of these can be observational, some of them can be interventional, so again, involving a new drug. And so UCLA has a table, and I encourage you, as well as kind of our other partners, to see if some of these clinical trials fit you and your family and to be involved. We actually right now have a trial for agitation, which is actually rare. There's a lot of excitement and trials for, again, early intervention, early memory symptoms. So we are in a unique position. We have an agitation trial going on, so please spread the word. The next important thing is that each person kind of has to take care of themselves. The only way that we help other people is that we take care of ourselves first. And then just getting involved, attending things like this. I'm very thankful to be part of it, and I hope it's helpful to you too.
Questions for Dr. Wu?
With regards to agitation, so often it's the caregiver approach that can shift and change. I just wanted to refer to Tipa Snow and it's teepasnow.com. She's got a much more respectful to the patient, but still effective for the care provider approach. And she's been a tremendous resource so that sometimes you don't have to medicate because medications consistently are going to have side effects. And a lot of them can make the situation worse. And then also to provide the reminder that UTIs cause strange behaviors. So always be aware of that.
Thank you. So I see in the back, we've got Natalie.
Yes, hi. My husband has dementia, Alzheimer's most likely. Agitation. He gets mostly agitated around taking a shower, and I know that that's common, and I'm curious to the reason for that. And also around toileting, it has to do with helping him to take his pants down. It's obvious to all of us that he's embarrassed and he wants control. Other than that, he's not agitated. So how do you go about that? He is on Seroquel, which I don't know if that's doing anything or not because it's like 2 times a day. So how do you approach something like that?
Thank you for your question regarding agitation that seems to be exclusive to showering and toileting. This is actually a common phenomenon, and ultimately, I think the reason is because people feel very vulnerable when they're being essentially asked to disrobe, kind of be in the bathroom with other people. The insight to all of that, the idea that, oh, someone is there to help me, like the linkage of that is not always happening. And ultimately, I think it comes from a place of self-defense of why are there people in the bathroom with me while I'm showering, or why are they making me take off my pants right now, and kind of the all of the thoughts around that just are they're fragmented. I would say that when it's exclusive to specific activities, I totally agree. The approach is probably 80%. The language that you use, I think actually kind of giving people some, talking them through it. It is, just saying, it is Saturday. It's the time to take a shower now because we didn't take a shower yesterday. We're going to take a shower today. I think giving them some prep, kind of talking through what's going to be happening, is again just giving them some dignity without kind of invading their personal space. Ultimately, again, sometimes we do use what's called kind of pre-medication, so timing the dose of a medication before the activity. And also just knowing the person. If mornings are better, shower in the morning. Some people get, again, they're sundowning, and so as the day goes on, they get more confused. And so if you know that to be the case, you try to kind of modify the schedule so that the shower is happening in the morning. Toileting, unfortunately, happens all day long, all night long. And so again, it's challenging, and I think this is really when the support groups and when really to see what's helping with other families might help you.
So I agree, savvy caregiver. You'll learn a lot. So we're going to move on. Steve over here has a question.
Hi, thank you for your presentation. I have a question for you. How often do you see where someone presents well to the community at large and they're still functioning? I'm talking about my mom. She's 93. She's still driving, but the brunt of the agitation and psychosis is based on the family, my sister, me, my dad. And so when I see some of the agitation and hallucinations and those things, it seems like she's moderate, but to the world she presents well. Someone like that, knows what they want to do, and you can't talk to them with some of those suggestions. So I was just wondering if you could say something about that situation.
Thank you for your question. I think people are fascinating, and some people have a lot of reserve. They can kind of hold the glue together and present well when in short in kind of short encounters. They may have more presence of mind of, like, again, when they're around strangers, they may act a certain way. They may still kind of hold that. But then the people that they're closest to, in fact, their family who knows them the best, They can't keep that glue together. And so kind of that's when these symptoms, might present themselves the most. Partly is it, because you're spending more time with them, or is it more because ultimately they can be themselves around family members most? Again, not everyone goes through the same journey, but I would say that that does happen. I think it makes it much more challenging for the family. And it's really why family members eventually are key to these appointments that I have with the patient, because at some point their perspective is not as reliable. And I really, really value the input from family members, because they really have they see what's going on.
Thank you, Dr. Wu. I'm going to be talking to you today about emerging research. What's next? Here's my disclosures. Okay, so we saw a version of this, I think, now 2 other times today. So we're going to go over this one more time, okay? So when we talk about the clinical stages of Alzheimer's disease, there are 3 stages. So you have people who are cognitively normal, nothing's going on. Then there are people who have mild cognitive impairment. That means that they've had some cognitive change, either in language or memory or something like that, but they're still functioning fine, still paying bills, still going to the grocery store, still able to take care of all the things that they need to do. And then there's dementia. And dementia just means that you've had a functional decline that accompanies the cognitive decline. So not only might you have memory problems or problem-solving problems, but now you aren't able to pay the bills without help, take medications without help, drive, do the things that you were always doing. And as Dr. Chui pointed out, during the time that people are cognitively normal, you see that red line of amyloid, it could be building up very silently, and so does tau. But still people are fine. And then by the time they come to our office, they might have hit mild cognitive impairment, and already that tau and the amyloid has been percolating along for a while. This is the goal of clinical trials, is to focus on how do we intervene earlier, and how do we detect these things earlier so that we can intervene, right? Because we're trying to not get to dementia. We're trying to stop things before that happens. I'm going to be talking to you a little bit today about what is out there, what's going on in the research world. So this is the CADRO system. It stands for Common Alzheimer's and Related Dementias Research Ontology, and ontology is just a big word for classification. So this CADRO was put together by the National Institutes on Aging and the Alzheimer's Association to look at how can we organize and think about what are all the different targets that we should be developing drugs for Alzheimer's disease. Because although amyloid and tau are the big players that we've heard about for a long time, actually, it turns out that Alzheimer's disease is really, really complex. And it's not all about amyloid and tau. There's all these other things and approaches that we need to be exploring. Even though you see amyloid and tau are at the very top, there's also inflammation. There's also talking about the vessels in your brain, metabolism, genetics, the gut-brain connection. In fact, we think that the gut-brain connection is very important. Your gut is probably the largest part of your nervous system. And we think that Parkinson's disease actually starts in your gut and moves its way back up into the brain. Maybe Alzheimer's works that way too, we don't know. So these are the things that we are trying to figure out as ways to target Alzheimer's disease. This is the 2025 Alzheimer's drug development pipeline, and it is very complex, but at the end of it, you will be able to understand it. There are 182 trials right now for Alzheimer's disease, which is incredible. And there are 138 new drugs in development. A third of them are drugs that are actually repurposed. So these are drugs that were developed, say, for other conditions that now might actually be able to be used for Alzheimer's disease, or they are molecules that were created and then maybe put into the drug library and haven't actually been used and now are being used towards Alzheimer's disease. Let's attack this diagram, shall we? The outer ring are phase 1 drugs. So as Dr. Grill may have mentioned, phase 1 are these small trials, usually people who are healthy, and they don't have that many in them. And the whole purpose is to really figure out what's the toxicity level, is it safe, some of those properties. The middle ring is phase 2.
These are studies that are actually targeted at people who have the particular condition. So people, in this case, who may have Alzheimer's, they may have mild cognitive impairment or mild dementia, say, to Alzheimer's. And then the inner circle is phase 3. These are the large trials that have several thousands of people who have, say, mild cognitive impairment due to Alzheimer's disease. And we are really trying to figure out now, does this drug work to improve or to slow down cognitive decline? Does it work to slow down functional decline? That's what that very center is. And you can see it takes a while. Yeah, it takes sometimes to get from phase 1 to phase 3, it could take 15 years. It takes a long time. But what you can see between these 3 layers is, look how many drugs are in phase 1 and phase 2. That's pretty great. We didn't used to have that many medications in the pipeline. So that's really encouraging. So now we're going to look at this diagram a different way. We're going to look at the pie slices. So the top pie slice is green, and this is the disease-targeted biologics. So what does that mean? So a disease-targeted biologic is basically a medication where it was created, say, from a protein or an antibody, something that comes from human tissue and then gets developed. So it's a large molecule, and these tend to be drugs that have to be infused by IV or injected because they're very big molecules, and if you take them by mouth, they get disintegrated. But they're very targeted at the biology they're working on. So for example, if you look at the very center, and you can see donanemab is there, right? You just heard about donanemab from Dr. Chui. So that is a biologic. Lecanemab, that's a biologic, and that's a disease-targeted biologic. Now, if you look at the purple slice of this pie, this is a disease-targeted small molecule. So they're also targeting the disease, say amyloid or tau or something, but now you're talking about something that was created synthetically, and it's usually a pill form, so it's usually something you can take by mouth. If you look at the turquoise pie, these are things that are neuropsychiatric symptom treatment. So as Dr. Wu was just talking about, these are medications that are being developed to help with agitation and psychosis, irritability, things like that. And then lastly, you have the orange triangle or the orange pie piece, and that's cognitive enhancers, or what's sometimes called nootropics. So these are medications that are used to enhance somebody's ability to think. So oftentimes they're used actually in people who are healthy, don't have any cognitive problems, but sometimes they are used with people who have cognitive problems. And these are not so much targeting a specific protein. They're just trying to boost up function in general. So those are the pie pieces. So we now have the phases and the sort of classifications of like what the drug, how it's been made. Now we're going to talk about these shapes. So these shapes tell us what phase of the disease is this trial targeted at. The triangles are for people who have normal cognition. And if it's an upwards triangle, it means that these are people that really have no issue at all in terms of their cognition, but also are not at greater risk for developing the disease, but are volunteers. So these are healthy controls. The downwards triangle, these are people who are also not going to the doctor for any memory problems. They don't have any memory problems. They're fine, but they are at risk. And that might be because they screened for a trial and it turns out they have, say, elevated amyloid levels in their brain, right? So now they can be part of, say, an early trial where they're trying to figure out if a medication might be helpful at a very early stage, but they don't have any cognitive issues. Then the circles are for people who have mild cognitive impairment. And then you have the squares and the pentagons. So the squares are for people who have mild dementia, and the pentagons are for people who have moderate and severe. Okay, so that's the shapes. And now we're going to come full circle, and we're back to Cadro. So in the upper left, you see all those colors. And all those colors are filling in all these shapes. So now what you can see is that all these different shapes are colored in by different cadres. So you can see which trials have which mechanisms, right? So some of these drugs are targeting amyloid, some are targeting tau, some are targeting inflammation, some of them are targeting synapses, some are targeting genetics. So that's how you read this table. And what's really cool now, if you look at it, is look how many trials there are in phase 1, in phase 2, and look at all those colors. Many colors. So there's many different drug targets that are being developed, that people are looking at, that we can attack this disease from many different directions, and look at all the different stages of disease, right? So it's for people who don't have any cognitive symptoms at all yet, people who may have mild cognitive impairment, people who have mild dementia. Those are the predominant people and the predominant studies that are out there. We're going to move on and talk a little bit about some of the drugs that are and the mechanisms that are out there. So first I'm going to talk about the blood-brain barrier. So the blood-brain barrier is basically a layer of cells that surround your arteries, right? You have arteries and veins that are going throughout your whole body, and they have to go to your brain, right? Because they have to deliver oxygen and they have to take back the carbon dioxide, right? So, but when things go to your brain, we don't want to let everything go to your brain. And so there's an extra layer of cells that protect the brain vessels so that not everything goes into the brain, and that's very important. However, that means it's harder to get drugs into the brain, right? Because you're not going to just let anything go in. You're only going to let small, important things, but you don't want infections to go into the brain. So that means that only about 1% to 5% of medications actually get into the brain itself. And so that presents a problem if you're trying to get drugs to treat the brain into the brain. You might increase the amount of drug that you have, but then that could be harmful, right? It may not be good for other parts of your body if you have to increase medication doses. One of the things that scientists have been working on is how do you get medication into the brain and past the blood-brain barrier? We're going to talk about number 1 and number 3 in terms of how they do that. So here's number 1. This is using focused ultrasound. Ultrasound is just sound waves. It just pings things and rattles things around. So what they do is they can give you an IV, and they can give you a saline, and they can give you air bubbles, basically. And the air bubbles go into that IV, go through your arm up into your brain, and there are air bubbles that when they hit your brain, they use the focused ultrasound, and the ultrasound, that sound wave hits the bubbles, it makes the bubbles knock around, which hits the brain barrier, and it opens it up a little bit. It sort of opens up those tight junctions and allows things to get into the blood-brain barrier into the brain. So now what they can do is they can give you medication at the same time that they give you those air bubbles, and the medication and the air bubbles go back up. They hit you with a focused ultrasound, and now the air bubbles open up that barrier, and now the medication can follow right behind, and so you can get better penetration that way. One of the studies that I know made a splash on 60 Minutes was this study that many of you have heard about, probably, where Dr. Rezai in West Virginia is using this technique to see if he can improve medication getting into the brain. So these are MRIs. If you look on the far left, this is somebody's brain. And if you can see the second brain over on the left, the outline of the green is where they're using the focused ultrasound. That's where they're going to target the focused ultrasound. The next one, over the third over from the left, you can see in the yellow box, this is where not only did they have the bubbles go up there, they also used tracer to show, like, are we able to open up the blood-brain barrier and get things to go where it needs to go? And the answer is yes, because you can see all that white tracer. So it was able to get into the brain. And then the last picture on the right is 48 afterwards. So what it's showing is there was no harm, like no injury afterwards. The brain looks fine again. So they were able to do it safely. So then what did they do? He took aducanumab, which was one of the medications that Dr. Chui mentioned. It's not on the market anymore. But they were able to basically use two halves of the brain. One is the test case with the focused ultrasound. The other side is the control. And they were able to identify a part of the brain in the frontal lobe that's outlined in white. That's where they were going to use the focused ultrasound. So in this person, they gave them the IV with the bubbles, and they also gave them aducanumab, which is a drug that pulls amyloid out of the brain, just like donanemab and lecanemab. And what you can see is on the top row, this was at baseline, and all that red, that's an amyloid PET scan. So there's a lot of red, there's a lot of amyloid in that brain. After 26 weeks, what you can see is if you compare both sides of the brain, you can see that the brain that had the focused ultrasound, you can see there's decreased red there. So they were able to pull amyloid out of the brain. So that's pretty cool. This has still got a long way to go, but it is very interesting. So now we're going to talk about a medication that's trying to do the same thing and cross the blood-brain barrier as well. This is trontinemab. This is a medication that has just completed phase 2 and is going to be going into phase 3. It is for people who have mild cognitive impairment, and its focus is amyloid, but it uses this interesting brain shuttle. What it does is the pink is the drug. So that's what's attacking the amyloid. But it also has this key, which is green. That's the shuttle. What happens is that key fits into a lock. That lock naturally exists on the blood-brain barrier. It's a transferrin receptor. So what they did is they added something onto the drug that they knew would fit onto this receptor. And when the receptor sees that, it's like the key in a lock. It unlocks it, and it actively helps the drug get across the blood-brain barrier instead of passively, the way most drugs work now. And then with that, then the drug part, the pink part, can attack all the amyloid plaque, along with the help of microglia. So this is very exciting, and you can see here that on this study, they tried placebo in gray, and they have 2 different dosages in the purple and the blue. And after 12 and 28 weeks, you can see that there's a significant decrease in amyloid, and it's probably faster than what we have now in terms of medications. And they are actually falling below that dotted gray line, which is considered, underneath, is considered to be a normal amount of amyloid in the brain. So you can see it was really able to lower the amyloid. And if you look at the scan pictures over there, you can see at baseline, people have red, those are the amyloid PET scan, but after 28 weeks, see with each one, you can see that there's less red. So the amyloid is decreased. So this is going to be going into phase 3, and it's going to be a very exciting trial. Here's another mechanism of action. This is now for people with mild cognitive impairment and mild dementia, and it is targeting the synapse. So what is a synapse, you might ask? So a synapse is the space between neurons. So neurons aren't actually connected. There's actually spaces between the neurons, and they communicate by chemical, and there's always a space between there. And what happens is that amyloid gets in between those synapses, gets in the spaces and gets in the way, and therefore neurons can't communicate effectively. So what this drug, it's CT1812, what it does is it gets in the way of allowing the amyloid to get there, and it protects those neurons and those synapses, hopefully so that they can continue to communicate. So this is pretty interesting because we haven't had any synaptic drugs, really. So it'll be interesting to see what happens with this. This is still phase 2. Now we're going to lastly talk about tau. And tau, again, is the other important protein besides amyloid. And we know that it starts in the brainstem and then hops over to memory centers of the brain and eventually over time spreads throughout the brain, right? And it's really the key protein because it's important for the neurons. It helps neurons function. And when the tau starts to misfold, the neurons can't function, and that's why you start to have cognitive problems, because you need your neurons to be able to think and communicate. If the neurons are kind of failing because you have tau getting misfolded, then that's why you start to have problems. Here's tau. This is like just regular tau, okay? What happens sometimes is the tau will misfold, and it causes a seed, and somehow it signals to all the other proteins, hey, you should start misfolding too, so they all do. And eventually they may stack on each other and become tau tangles, okay? So in a neuron, there's tau, and sometimes tau leaves the neuron, and that's normal. So it may leave it, but something might happen, and for some reason, the tau might misfold. It causes other tau to misfold, and before you know it, it's tangling, and now it's sending a signal to the healthy neuron, hey, start misfolding, and then the tau gets that signal and starts misfolding, and we have a problem, right? Because that's how things are spreading. With that background, now that we're clear on this last drug, this is E2814 or edelanotug. It just got its name, so we're all still practicing it. And so you can see, here's our neuron on the left, and so the neuron has the tau, and it's getting cut at different lengths. That's normal. The body just kind of cuts the tau into different lengths. It gets released, right? So now it's in the synapse, and some of these fragments have a certain region, the yellow region, which is also called the microtubule binding region, where it's going to want to keep clumping to itself, and that's a problem. So what this drug does is it comes in, you see those little Y-shaped things, that's the drug. It's an antibody, and it's detecting that yellow section. It gloms onto it, and therefore then brings in the microglia to chomp everything up, and it's trying to prevent that next progression to the next neuron, right? So it's mopping up all of those tau tangles that are forming. Pretty cool. So this is an infusion, a tau infusion. And it is for people who are at risk for developing Alzheimer's, but they are healthy, right? So you see it's an upside down triangle, so they're healthy and don't have any cognitive problems. And it's also for people with mild cognitive impairment. So that's who they're testing this in at the moment. This is in phase 2 as well. So there are so many other drugs, as you know, that we didn't used to be able to put up a pipeline like this. So there are so many trials out there. The biggest thing to take away is that there are so many new approaches. And honestly, in order to be able to take care of this disease, it's not going to be one medication. We're going to be using different medications. And we're probably going to be using different medications at different stages of the disease. We just don't know which ones yet because we're still at the beginning of this adventure. Lastly is really to emphasize what everybody else has said, which is we need your help. Consider being in a clinical trial, because that's the only way that we're going to move this forward and understand and be able to really understand why does this disease happen and how can we treat it. So that's it. Thank you.
Questions for Dr. Kremen? Okay, over here.
On your 3-ring circle chart,
Yeah.
why are there only 2 drugs aimed at tau?
It is really hard to get from phase 1 to phase 3. It's really hard to get that far. So, you start with a huge funnel, and you're hoping that with each phase, you're going to make your primary endpoint, right? And the thing is that at phase 2, the primary endpoint usually still has to do with safety, but sometimes there's efficacy as well, like, did it meet the target, and maybe like, did it help? Did it look like it was going to help cognitively? But sometimes it just doesn't make it. It's just really hard. So we start with a lot. So that's why it's a great feat that we have the medications that were just approved even now, because it took so many years to get to that. Yeah.
At the back.
What are the side effects of the tau medication?
I am not involved with them, and I don't really know. But when we go to the conferences, the big ones are clinical trials in Alzheimer's disease and also Alzheimer's Association International Conference, and there's some other ones as well. That's where they will usually announce if there are any major side effects. I don't think there have been any major ones with tau. Certainly nothing like ARIA that I've noticed, but we'll have to see.
Over here, Steve.
Hi, thank you so much. This was fantastic and a great way to end the day. How is the federal defunding of research impacting or expected to impact Alzheimer's research?
Right. Some of the medications obviously are being developed by the big pharma companies, and hopefully their funding is okay. Where it affects things is probably the smaller trials, the ones that are being developed by investigators at universities, or sometimes there's private-public partnerships, right, between, you'll have NIH will fund part of it and a company will fund part of it, and so we may be losing out on that. So it is a concern also at the basic research level, or trying to get, things that are in preclinical, like things that are still being done in the mice or organoids or things like that, and trying to push them to phase 1 takes a lot. So, there may be some impact. That said, we will wait to see, because it looks like Congress doesn't really want to affect this area of research, and so hopefully funding is going to be okay.
Kelly's got a question over here in the front.
Around the world, there's Alzheimer's. In some of the places, they're using herbal remedies like Bacopa, Monera. Is there anything that's going to happen in research here to use natural substances?
There are definitely medications or early substances that we didn't even put up here. You're absolutely right. The issue is not that there's anything wrong with them. It's been harder. There have been less trials. So people use them, but we don't know what the efficacy is. Like, for example, there's been a study of ginkgo, so we know something about that. There was a trial for resveratrol, so we know something about that. The problem is with these other things like Bacopa and other things that people will sometimes come into clinic on, is that it's hard for us to advise only because we don't have a trial to actually hang our hat on and say, this is what we know, even though from a mechanistic point of view, they make sense.
Natalie in the center.
How does the tau medication get across the brain barrier?
It depends so it may not be, right? Because there's only some that have that mechanism. So that brain shuttle is specifically an amyloid drug, and I don't know if they're doing any studies at this point using focused ultrasound plus the tau drugs. We'll have to see.
Okay, Steve, last question in the back with Steve.
Hi, I was wondering if there's a connection between the decline in estrogen and dementias.
Do you have all day? It's a really complex topic. The long and short of it is that the brain has a lot of estrogen receptors, and we do think that there's a hypothesis that with menopause, there's a drop, obviously, in estrogen, and therefore there may be parts of the brain that are significantly affected by that and not having the ability to use the estrogen because it's not there anymore, and it affects cognition or might explain brain fog, etc. So that's the hypothesis. It's been really hard to figure out, though, what should we do about it? Should we be doing something about it? Should we not be doing something about it? There was the Women's Health Initiative many years ago that showed that estrogen was harmful. However, it wasn't exactly the same population. So anyway, the literature is really confusing, and you can find data to support it or to refute it. So I'd say it's just really complicated. Sorry, I don't have a better answer.
So thank you, Dr. Kremen.